Hello, everyone. I'm Dr. Zhang, a board-certified medical oncologist and integrative medicine practitioner. Thank you for joining me today as we explore a compelling topic, off-label medicine in cancer care. In my practice, I often encounter patients who inquire about the potential use of certain medications, like ivermectin or fenbendazole. These inquiries revolve around the concept of off-label use, which involves the utilization of drugs outside their approved indications by FDA. In fact, off-label use is a common practice in medicine, where medications are prescribed for purposes not explicitly approved by the FDA. While this may sound concerning, it's important to understand that off-label prescribing is legal and widely accepted in the medical field. In fact, more than 1 in 5 outpatient prescriptions in the US are for off-label uses. When a medication is prescribed off-label, it is being used in a manner not specified in the FDA-approved packaging label or insert. Once a medication is approved for one purpose, doctors can prescribe it for other conditions or patient populations if they believe it to be medically appropriate. For example, let's consider the drug prazosin, which is FDA-approved for treating hypertension. While its approved use is to lower blood pressure, doctors may also prescribe it off-label to manage nightmares related to post-traumatic stress disorder. Similarly, quetiapine is approved to treat schizophrenia, bipolar disorder, and depression, but it may be prescribed off-label to address conditions like insomnia or dementia. Another drug, gabapentin, is approved for seizures, but is also used off-label to manage anxiety, alcohol withdrawal, hot flashes, or restless leg syndrome. Today, I want to shed light on off-label drug use in cancer, which is an important aspect of cancer treatment. Before that, let me provide a brief background on my research into off-label medicines. After completing my fellowship at Yale, I started using an off-label medicine called Octos. Pioglitazone is the generic version of Octos. It is an oral diabetes medication for adults. Surprisingly, I observed positive results in several of my patients. Motivated by these outcomes, I pursued further research at Baylor College of Medicine in Houston. Collaborating with esteemed researchers from the Texas A&M Research Institute and MD Anderson Cancer Center, and with the support of the Duncan Scholar Fund, we conducted thorough investigations and studies on various off-label medicines. I am excited to share with you today the current status of this intriguing field. You should know that, in fact, off-label use is quite common in oncology, with estimates suggesting that a significant percentage of adult cancer patients, from 13% to 71%, receive off-label drugs during their treatment. However, off-label use poses challenges in clinical decision-making and places a significant level of responsibility on the prescribing practitioner. It becomes crucial for healthcare professionals to thoroughly examine the scientific evidence and available data for each medication being considered for off-label use. By critically analyzing the science and data behind non-cancer drugs used for cancer treatments, we can make informed decisions that prioritize the best possible care for our patients. This involves exploring the available research, conducting comprehensive studies, and adhering to relevant guidelines to determine the potential benefits and risks associated with off-label use. Taking a meticulous approach to scrutinize the evidence allows us to navigate the complexities of off-label medicine and make sound decisions that prioritize patient well-being and safety. I am thrilled to explore further into this topic and share valuable insights with all of you today.
The information, including but not limited to text, graphics, images, and other material contained in this presentation, is provided for informational purposes only. None of the material is intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment, and before undertaking a new healthcare regimen. Never disregard professional medical advice or delay in seeking it because of something you have read or heard on this presentation.
The quote by Hippocrates, "As to diseases, make a habit of 2 things, to help, or at least to do no harm," carries profound significance in the field of medicine. While the principle of do no harm is commonly emphasized and followed, Hippocrates reminds us that the primary focus should be on providing assistance and aid to those in need. By highlighting the importance of helping, Hippocrates emphasizes that healthcare professionals should actively seek opportunities to make a positive impact on the well-being of their patients. Merely refraining from causing harm is not enough. They should strive to offer genuine assistance and support in combating diseases and improving overall health. Furthermore, Hippocrates acknowledges the interconnectedness of three essential factors in the medical field: the disease, the patient, and the physician. This recognition reflects the holistic approach to healthcare that emphasizes the multifaceted nature of healing. The physician is positioned as a servant of the art, indicating a sense of duty and responsibility to provide the best possible care for the patient. In this context, the patient's active participation and cooperation become crucial. Hippocrates emphasizes the importance of a collaborative relationship between the patient and the physician. Both parties must work together to combat the disease effectively. This underscores the significance of open communication, trust, and shared decision-making between healthcare professionals and patients. Ultimately, Hippocrates' quote serves as a reminder that the fundamental goal of medicine is to provide help and support, going beyond the mere absence of harm. It calls upon healthcare professionals to approach their practice with compassion, empathy, and a commitment to making a positive difference in the lives of those they serve. At the heart of innovative off-label use of cancer treatment lies the Repurposing Drugs in Oncology, in short, ReDo project. This unique initiative is focused on unearthing new oncological applications for existing non-cancer drugs. In essence, drug repurposing seeks to unlock the potential of well-understood, non-cancer medications, positioning them as valuable assets in cancer treatment. This process may involve integrating these repurposed drugs into existing treatment regimens or creating novel therapeutic combinations. Indeed, drug repurposing stands as an underexplored reservoir teeming with potential breakthroughs in therapeutic innovations. The ReDo project is the successful outcome of an international collaboration among a diverse set of researchers, clinicians, and patient advocates such as Global Cures from USA and Anti-Cancer Fund from UK. Its fundamental goal is to discover effective, low-toxicity cancer treatments that are not only cost-effective but can also be quickly made available to patients in need. Although there is a myriad of potential candidates for drug repurposing, only a select few are backed by substantial, supportive evidence. This evidence can often be scattered, unconsolidated, or obscured, creating an additional challenge. In response to this, the ReDo project has taken the initiative to identify the most promising drug candidates for extensive clinical investigation. The project also meticulously documents potential combinations of these repurposed drugs with existing therapies. By doing so, the project aims to amplify the potential impact of these medications in our fight against cancer. Through these efforts, the ReDo project ushers in a brighter, more hopeful era in the quest for effective cancer treatments. The ReDo database is a key resource in the field of drug repurposing, and has so far identified over 300 non-cancer drugs that exhibit promising anti-cancer effects as evidenced by published research. These drugs serve as prospective candidates for the development of novel cancer therapies. Significantly, more than half of these identified drugs have already undergone human clinical trials, further underscoring their potential for application in cancer treatment. Out of the hundreds of medications reported in medical literature as potential oncology treatments, about 50 of them are backed by reasonably strong clinical evidence. Today, we will proceed to discuss some of these commonly utilized in our clinical practice. Here are some examples of off-label drugs commonly used in oncology practice. Antibiotics. Some antibiotics like doxycycline and azithromycin have shown anti-cancer properties, especially in combination with other cancer therapies. These antibiotics can inhibit protein synthesis in cancer cells, disrupt cancer cell growth and proliferation, and enhance the cancer-killing effects of other therapies. For instance, doxycycline has been shown to inhibit cancer stem cells, which are often resistant to standard cancer treatments and can contribute to cancer recurrence. Nonsteroidal anti-inflammatory drugs, NSAIDs. These include drugs like aspirin and ibuprofen. Long-term use of aspirin has been associated with reduced risk of certain types of cancer, such as colorectal cancer. These drugs can suppress inflammation, a key factor in cancer development and progression. Cardiovascular drugs, statins, typically used to lower cholesterol, have been observed to have potential anti-cancer effects, possibly by inhibiting the mevalonate pathway, which is essential for the synthesis of cholesterol and is often upregulated in cancer cells. Antidepressants. Certain antidepressants, such as tricyclic antidepressants and selective serotonin reuptake inhibitors, SSRIs, have been reported to possess anti-cancer properties, potentially through mechanisms such as inducing apoptosis, programmed cell death, and inhibiting angiogenesis, the formation of new blood vessels that feed cancer cells. Antidiabetics. Drug S for alcohol addiction. Disulfiram, a drug used to support the treatment of chronic alcoholism, has shown promising results in preclinical studies as an anti-cancer agent. Its proposed mechanism involves the inhibition of the proteasome complex in cancer cells, leading to cell death. Each of these drugs targets different hallmarks of cancer, including resisting cell death, inducing angiogenesis, activating invasion and metastasis, enabling replicative immortality, evading growth suppressors, and deregulating cellular energetics. Let's start by exploring the science behind off-label medicines and their mechanisms of action. Metabolic studies have revealed that cancer cells can have diverse nutrient preferences, and they are not always predictable. For instance, certain subsets of cancer cells exhibit metabolic plasticity, enabling them to switch between or utilize both glycolysis, the breakdown of glucose, and mitochondrial respiration, energy production within the mitochondria. On the other hand, some cancers may rely more heavily on mitochondrial respiration. Given this complexity, it becomes crucial to use a combination of off-label medications, in a cocktail approach to target all possible pathways, involving glucose, fat, and amino acids. Jane McClellan Metro Map provides a visual representation of this approach, showcasing the combination of medications used to inhibit specific pathways. Glucose pathways can be targeted by medications such as statin, metformin, doxycycline, and niclosamide. The fat pathway can be inhibited using statin, dipyridamole, doxycycline, and hydroxychloroquine. Additionally, the glutamine pathway can be blocked using metformin, doxycycline, niclosamide, and dipyridamole. By utilizing a combination of these off-label medications, it becomes possible to simultaneously target multiple pathways involved in glucose, fat, and glutamine metabolism. This approach aims to disrupt the metabolic processes necessary for cancer cell survival and proliferation. The impact of off-label medicines on cancer biology extends far beyond metabolic reprogramming and the use of Metro Map. With an ever-increasing volume of medical data, hundreds of off-label medicines have been found to affect the complex interplay of cancer phenotypes and genotypes, commonly referred to as the hallmarks of cancer. For instance, the anti-helminthic drug niclosamide has demonstrated anti-cancer effects by modulating signaling pathways, such as Wnt, STAT3, and NF-kappa-APA-B, which are hallmark pathways involved in cancer invasion and metastasis. Inflammation, recognized as a hallmark of cancer progression, has been targeted with drugs like aspirin, leading to inhibition of inflammation and regression of cancer. Interestingly, some compounds have shown unexpected ways of killing cancer cells, exhibiting anti-cancer effects by interacting with previously unrecognized molecular targets. For example, several diuretics were found to affect genome instability, and drugs like compazine and thorazine were shown to suppress TERT, and therefore reduce replicative immortality. Moreover, digoxin selectively killed senescent cancer cells. Furthermore, several off-label medicines, including disulfiram, metformin, doxycycline, and itraconazole, have been identified to specifically target cancer stem cells, which play a crucial role in cancer progression and drug resistance. These findings highlight the diverse mechanisms through which off-label medicines can impact cancer cells. They may interact with known pathways, or target previously unknown molecular targets within the cells. It is important to note that further research is needed to fully understand the precise mechanisms of action for these off-label medicines, and their potential clinical applications. Let's start with benzimidazole anthelmintics. These medications have a chemical structure of benzimidazole, and exhibit broad anthelmintic activity. They are widely used in both human and veterinary medicine, to control internal parasites. Since their introduction in the 1960s, benzimidazole anthelmintics have gained popularity worldwide, due to their effectiveness and affordability. One notable advantage of benzimidazole anthelmintics is their favorable tolerability profile, with no severe side effects reported. Their extensive use over several decades provides a solid foundation for their safety in human patients. Mechanistically, benzimidazole anthelmintics exert their action by selectively binding to beta-tubulin proteins found in parasitic worms. This interaction leads to the immobilization and subsequent death of the worms. Given their specific interaction with microtubules, benzimidazole anthelmintics have garnered interest as potential anti-tumor agents. Researchers have extensively studied their ability to disrupt tubulin polymerization, paving the way for drug repurposing in the field of oncology. In this discussion, we will focus on the anti-tumor effects of three benzimidazole anthelmintics, commonly used in human or veterinary practice: albendazole, mebendazole, and fenbendazole. As we just mentioned, benzimidazoles function by selectively binding to beta-tubulin in parasitic worms, leading to their paralysis and subsequent death. Furthermore, they have demonstrated effectiveness in combating cancers that exhibit resistance to paclitaxel and doxorubicin. The anti-tumor effects of benzimidazole manifest through several mechanisms, including inhibition of cancer cell viability, migration, and invasion. Reduction in colony formation, an essential part of cancer proliferation. Disruption of tubulin polymerization, impacting the structural integrity of the cells. Induction of apoptosis and autophagy, leading to programmed cell death. Enhancement of cell cycle arrest, controlling the cell division process. Promotion of differentiation and senescence, pushing cells toward a more mature and non-dividing state. Induction of multinucleation, which often precedes cell death. Reduction in angiogenesis, restricting the growth of new blood vessels needed for tumor growth. Inhibition of drug resistance mechanisms and cellular transporters. Impairment of glucose utilization, an essential energy source for cancer cells. However, benzimidazoles are characterized by low water solubility and poor gastrointestinal absorption, reducing their bioavailability. The good news is, co-administration with a high-fat meal may significantly enhance the absorption of benzimidazoles, potentially overcoming their bioavailability limitations. The effectiveness of albendazole has been demonstrated in early clinical trials. 36 patients suffering from refractory solid tumors were enrolled in this study. The main challenge faced was myelosuppression, which emerged as the principal dose-limiting toxicity. Participants also reported fatigue and mild gastrointestinal discomfort. However, it's noteworthy to mention that out of 24 assessable patients, 4, representing 16%, displayed a tumor marker response. Alongside this, we observed a decline in plasma vascular endothelial growth factor levels. Furthermore, albendazole was well tolerated according to the schedule tested. Based on these findings, the recommended dose for subsequent studies is 1,200 mg, administered twice daily for 14 days within a 21-day cycle. Albendazole, a commonly used antiparasitic drug, is known to have several adverse effects. These often encompass neurological symptoms such as headaches, nausea, vomiting, increased intracranial pressure, and meningeal signs. In addition to these, the drug may incite various systemic effects such as elevated hepatic enzymes, abdominal pain, reversible alopecia, fever, vertigo, and dizziness. It's noteworthy to mention that nausea, vomiting, and headaches seem to occur fairly frequently among patients. From a hematological perspective, albendazole has been associated with bone marrow suppression, albeit this is a relatively rare occurrence, reported in less than 1% of patients receiving the drug. The drug can also influence hepatic function, with mild to moderate increases in hepatic enzymes reported in approximately 16% of patients participating in clinical trials. Typically, hepatic enzymes revert to normal levels once the drug is discontinued. However, instances of acute liver failure, of uncertain causality, and hepatitis have been reported. Mebendazole has demonstrated promising preclinical anti-cancer activity against various malignancies. Preclinical studies have suggested its potential efficacy in treating colon, brain, lung, and other types of cancers. There have been case reports and ongoing clinical trials exploring the repurposing of mebendazole for colorectal and other cancer types. One such case involves a 74-year-old man with metastatic colon cancer, who received mebendazole treatment at the Department of Oncology, Uppsala University Hospital. Histopathological examination revealed a moderately differentiated adenocarcinoma with a KRAS mutation. The patient had previously undergone palliative chemotherapy, with a combination of capecitabine, oxaliplatin, bevacizumab, and irinotecan, but experienced disease progression, with new and poorly defined liver metastases, measuring up to 8 cm in diameter. The patient was then initiated on mebendazole at the standard dose of 100 mg taken twice daily. Remarkably, the patient experienced no adverse effects from the treatment. Subsequent CT evaluation showed near complete remission of the metastases in the lungs and lymph nodes, along with a significant partial remission in the liver. This case highlights the potential efficacy of mebendazole as a repurposed treatment option for metastatic colon cancer. Mebendazole has a long-standing history of use in treating local gastrointestinal parasitic infections at lower doses, typically at 100 mg twice daily for up to 5 days. For more invasive infections, such as those caused by echinococcus, significantly higher doses, around 40 mg/kg per day, have been administered over extended periods, ranging from several months to years. A phase 2 trial was conducted to further explore these potential anti-cancer effects, enrolling about 10 patients. Mebendazole was administered up to its daily maximum dose of 4 grams, but the trial did not demonstrate a clear treatment benefit. From a safety perspective, mebendazole was generally well tolerated, even at the higher dose of 4 grams per day. Despite this, all patients experienced rapid disease progression, and 4 out of the 8 patients evaluated with CT scans met the criteria, suggesting hyperprogressive disease. At present, the relationship between exposure to mebendazole and potential stimulation of tumor growth remains uncertain. Speculatively, it's possible that for mebendazole to be effective in cancer treatment, it might need to be combined with a chemotherapy drug that halts tumor growth, allowing the presumed immune effect of mebendazole time to act. However, until further clinical studies are conducted, mebendazole is not recommended as a standalone treatment for cancer. Mebendazole exhibits excellent tolerability, even when administered at high doses and for prolonged periods. However, it is important to note the potential side effects associated with its use. These may include abdominal pain, vomiting, diarrhea, fever, headache, dizziness, drowsiness, convulsions, angioedema, rash, urticaria, hypersensitivity reactions, prolonged menstrual periods, agranulocytosis, and hepatitis. It is crucial to monitor patients closely and promptly address any adverse reactions that may occur. Niclosamide is an orally bioavailable chlorinated salicylanilide, and it is an antiparasitic drug indicated for the treatment of tapeworm infections in both adults and children. It is also utilized as a molluscicide for controlling schistosomiasis. Niclosamide received FDA approval in 1982. Previously marketed in the United States under the brand name Nicloside, niclosamide was voluntarily withdrawn from the market by Bayer in 1996. In recent years, niclosamide has gained attention for its potential as a multifunctional drug through drug repurposing screens, showcasing its versatility beyond its original indication. Niclosamide, derived from salicylamides, belongs to a class of potent mitochondrial uncouplers. Mitochondrial uncoupling refers to the dissociation between the generation of mitochondrial membrane potential and its utilization for ATP synthesis, a process essential for cellular energy production. As a mitochondrial uncoupler, niclosamide disrupts the coupling between the mitochondrial membrane potential and ATP synthesis. This unique property of mitochondrial uncouplers allows them to target multiple oncogenic pathways simultaneously, making them advantageous compared to other drugs. Niclosamide has been found to activate tumor suppressor signaling pathways, such as p53, pp2a, and AMPK, while inhibiting oncogenic pathways including Wnt beta-catenin, RAS, STAT3, Notch, E2F-MYC, NF-kappa B, and mTOR. This broad range of targets contributes to the anti-tumor effects of niclosamide. Additionally, niclosamide has been found to inhibit androgen receptor splice variant 7 or ARV7. ARV7 is a splice variant of the androgen receptor AR that has been implicated in resistance to androgen deprivation therapy in prostate cancer. Overall, niclosamide's ability to act as a mitochondrial uncoupler, modulate oncogenic pathways, and activate tumor suppressors makes it a promising candidate for cancer treatment with potential advantages over other therapeutic agents. The usual dose of niclosamide for adults is 2 grams on day 1, followed by 1 gram once daily for 6 days. In the context of arthritis, niclosamide has been repurposed with a dose of 1,000 mg per day for 8 weeks. For COVID-19 treatment, niclosamide is administered orally at a dosage of 2 grams daily for 7 days. Common side effects of niclosamide are uncommon. These may include decreased appetite, vomiting, diarrhea, taste impairment, and dizziness. A phase 1 trial conducted by doctors from the University of California investigated the use of niclosamide in hormone-refractory prostate cancer. The results from the trial indicate that, combining abiraterone, prednisone, and niclosamide is safe for patients with metastatic castration-resistant prostate cancer or mCRPC. Combination therapy was well tolerated, with the most commonly reported adverse effect being diarrhea. Among the 8 patients evaluated, 5 demonstrated a positive response in terms of prostate-specific antigen PSA levels, with 2 achieving undetectable PSA levels and a radiographic response. Although this particular trial focused on mCRPC, the potential impact of the combination therapy could extend to other types of cancer. Ivermectin is one of the members of the ivermectin family of lactone macrolides. It has a diverse range of applications. Originally discovered by Satoshi Omura and William Campbell, it was initially used as an antiparasitic agent in veterinary medicine. Over time, its use expanded to include the treatment of various parasitic infections in humans, such as river blindness, lymphatic filariasis, scabies, and head lice. Recent research has suggested that ivermectin may have potential applications beyond its established uses. In particular, studies have indicated its potential as an anti-cancer agent. Ivermectin has been found to inhibit multiple pathways involved in cancer progression. It can also induce cell cycle arrest, apoptosis, and the generation of reactive oxygen species. Additionally, ivermectin has shown the ability to inhibit the P-glycoprotein pump, allowing it to synergize with chemotherapy drugs, by preventing their extrusion from cancer cells. Furthermore, ivermectin can modify the epigenetic signature and self-renewal activity of malignant cells. Although ivermectin has shown promising activity in preclinical models of cancer, there is currently a lack of data regarding its efficacy in treating cancer in humans. However, we do have available data on the safety of ivermectin from studies conducted with healthy volunteers and patients with COVID-19. These studies have provided valuable insights into the safety profile, which will be discussed in more detail later on. While side effects of ivermectin are generally uncommon, they can include decreased appetite, vomiting, diarrhea, taste impairment, dizziness, and in rare cases, mild liver disease. A study was conducted to evaluate the safety and pharmacokinetics of ivermectin. Pharmacokinetics is study of how the drug is processed in the body. The study was double-blind and placebo-controlled, meaning that some participants received ivermectin while others received a placebo. A total of 68 subjects were divided into 4 groups, with 3 groups receiving different doses of ivermectin, 30 mg, 60 mg, 90 mg, or 120 mg, and 1 group receiving a placebo. The study aimed to assess the safety of ivermectin, including its potential effects on the central nervous system, and to measure its toxicity. The main safety measure was the assessment of mydriasis, which is the dilation of the pupils, and it was accurately measured using pupillometry. Overall, ivermectin was well tolerated by the participants, and there were no signs of brain toxicity even at doses up to 10 times higher than the maximum dose approved by the FDA, 200 microg per kilogram. The mydriatic effect of ivermectin was similar to that of the placebo, indicating no significant difference. Adverse experiences reported by participants were similar between the ivermectin and placebo groups and did not increase with higher doses. The pharmacokinetic analysis showed that, after single doses ranging from 30 to 120 mg, the concentration of ivermectin in the body and the maximum concentration reached were generally proportional to the dose. The time it took for the drug to reach its maximum concentration was approximately 4 hours, and the half-life of the drug was around 18 hours. In the group receiving 30 mg of ivermectin, concentration of ivermectin in the body was 2.6 times higher when the drug was taken with food. In addition, the study revealed minimal accumulation of ivermectin when given every 4th day. In conclusion, this study demonstrated that higher doses and more frequent regimens of ivermectin were generally well tolerated by the participants, with no significant adverse effects. The pharmacokinetic analysis provided valuable information on the drug's concentration in the body over time. We have learned more about the safety of ivermectin from COVID-19 trials. Ivermectin has garnered attention for its potential use in the treatment of COVID-19. Recent studies have investigated its effectiveness in combating the virus and its impact on disease outcomes. The study aimed to evaluate the effect of administering a higher dose of ivermectin, 600 g/kg, daily for 6 days, compared to a placebo, on the time to sustained recovery in outpatients with COVID-19. Some adverse events, such as cognitive impairment, blurred vision, light sensitivity to the eye, photophobia, dizziness, and asthma, were reported more frequently in the ivermectin group, compared to the placebo group. Although ivermectin has been extensively used as an antiparasitic, and has shown potential in treating other diseases, such as viral infections, it is surprising that there have been no reported clinical studies or trials exploring its effectiveness against cancer. However, there is a case report involving 3 children with acute myeloblastic leukemia, who were heavily pretreated and had refractory disease. In this report, ivermectin was administered at a dose of 1 mg/kg either alone or in combination with chemotherapy RSC. 2 of the patients showed clinical improvement, with one experiencing durable and stable disease and the other achieving a complete hematological response. The third patient, who received ivermectin alone, did not show any response. Although these findings are anecdotal, they suggest that ivermectin can be safely administered at higher doses, 5 times the FDA recommended dose, and may exhibit efficacy when combined with chemotherapy agents. However, more research is needed to determine the potential of ivermectin as a cancer treatment, and to establish optimal dosing regimens and combinations with other therapies. Doxycycline is a broad-spectrum antibiotic from the tetracycline class. It was patented in 1957 and became commercially available in 1967. It is one of the most commonly prescribed medications in the United States, with over 9 million prescriptions. Doxycycline is effective against various bacterial infections and certain parasites. It is commonly used to treat conditions such as bacterial pneumonia, acne, chlamydia infections, Lyme disease, cholera, typhus, and syphilis. Additionally, it can be used in combination with quinine to prevent malaria. Doxycycline works by inhibiting the synthesis of bacterial proteins through its binding to the 30S ribosomal subunit, which is specific to bacteria. One of the notable advantages of doxycycline is its excellent pharmacokinetics. It is well absorbed orally and has a long half-life in the bloodstream, typically ranging from 18 to 22 hours, when administered at the standard dose of 200 mg per day. The adverse effects of doxycycline are generally mild. It can cause gastrointestinal discomfort. When taken orally without sufficient fluid or by individuals with swallowing difficulties, it may lead to piloesophagitis. However, compared to other antibiotic drugs, doxycycline is less likely to cause Clostridium difficile colitis. A side effect associated with doxycycline is an erythematous rash on sun-exposed areas of the body. This rash has been reported in 10% to 20% of individuals taking doxycycline. Studies have shown that doxycycline does not significantly increase the occurrence of all skin events, including photosensitivity, when compared to other antimalarial medications. The rash typically resolves once the drug is discontinued. Unlike some other tetracycline antibiotics, doxycycline can be used in individuals with renal impairment, providing a treatment option for patients with compromised kidney function. Doxycycline has been found to have a potential mechanism in targeting cancer stem cells. It acts as a non-toxic inhibitor of mitochondrial biogenesis, by exploiting the similarities between bacterial ribosomes and mitochondrial ribosomes, which are evolutionarily conserved. By targeting mitochondrial ribosomes, doxycycline disrupts the process of mitochondrial biogenesis, which is essential for the survival and function of cancer stem cells. This mechanism is significant, because cancer stem cells are believed to play a crucial role in tumor growth, resistance to therapy, and cancer recurrence. By specifically targeting these cancer stem cells, doxycycline may have the potential to inhibit tumor progression and improve treatment outcomes. Doxycycline has also demonstrated selectivity in killing cancer cells while sparing normal cells. A pilot study was conducted to investigate the effects of doxycycline in breast cancer patients. The study involved 15 female patients with early breast cancer, with 9 patients receiving doxycycline at a daily dose of 200 mg for a period of 14 days, while 6 patients remained untreated. The results of the study showed that most of the tumor markers remained unchanged in the patients who received oral doxycycline, except for CD44, which is a marker associated with cancer stem cell-like properties. Specifically, the levels of CD44 were reduced by an average of approximately 40%. Notably, 4 out of the 9 patients showed reductions of 50% or greater in CD44 levels. In addition, 2 patients who belonged to the HER2-positive subtype of breast cancer exhibited positivity for another stem cell marker called ALDH1. Interestingly, in response to doxycycline, 1 patient experienced a nearly 60% reduction in ALDH1 levels, while the other patient showed a reduction of approximately 90% in ALDH1 levels. These findings suggest that doxycycline may have an impact on stem cell markers in breast cancer. In a Phase 2 randomized trial, the therapeutic efficacy of doxycycline was investigated in patients with mycosis fungoides, the most common type of primary cutaneous T-cell lymphomas. 36 patients were randomly assigned to receive either doxycycline at a daily dose of 200 mg, or PUVA therapy, consisting of 3 weekly sessions for 12 weeks. PUVA is the abbreviation of psoralen plus ultraviolet A therapy. The study's results showed that the partial response rate achieved with doxycycline was significantly lower compared to PUVA therapy, 11.1% versus 50%. Although the response rate with doxycycline was only about 10%, it is still clinically important, considering that this study evaluated doxycycline as a single agent, and it was associated with minimal side effects. These findings suggest that while doxycycline demonstrated a lower response rate, compared to PUVA therapy in patients with mycosis fungoides, its clinical significance should not be overlooked. The fact that doxycycline is a well-tolerated treatment option with minimal side effects makes it a valuable consideration for patients who may not be suitable candidates for more aggressive therapies, or who prefer a less invasive approach. Based on the results of a prospective trial, doxycycline has shown promise in the treatment of ocular maltoma, a type of lymphoma affecting the mucosa-associated lymphoid tissue in the eye. The trial included a total of 27 patients, with 11 testing positive for chlamydia psittaci infection DNA and 16 testing negative. All patients received a 3-week course of doxycycline therapy. Doxycycline was well tolerated by the patients, and at a median follow-up of 14 months, significant lymphoma regression was observed. 6 patients achieved complete regression of the lymphoma, and 7 patients showed a partial response, with a reduction of at least 50% in measurable lesions. This resulted in an overall response rate of 48%. Interestingly, lymphoma regression was observed in both chlamydia DNA positive patients and chlamydia DNA negative patients, with response rates of 64% and 38% respectively. It suggests that doxycycline may be effective regardless of chlamydia DNA status. The study findings demonstrate that doxycycline is a fast, safe, and active therapy for maltoma. Notably, the treatment showed effectiveness even in patients with multiple treatment failures, involving previously irradiated areas or regional lymphadenopathies. Now, let's take a closer look at the other 2 related antibiotics, azithromycin and clarithromycin. In a clinical study from Japan, the effects of azithromycin on chemotherapy for advanced non-small cell lung cancer were investigated. The study aimed to determine the impact of azithromycin when used in combination with standard chemotherapy regimens. 86 patients with stage 3 or 4 non-small cell lung cancer were randomly divided into 2 groups, one receiving chemotherapy with carboplatin and paclitaxel and the other receiving the same chemotherapy regimen along with azithromycin. The survival outcomes of the patients in both groups were analyzed. The results showed that the median survival time was 12.0 months for the chemotherapy group, while it was slightly longer at 13.0 months for the chemotherapy plus azithromycin group. Furthermore, the 1-year survival rates were 45.0% for the chemotherapy group, and 75.0% for the chemotherapy plus azithromycin group, indicating a significant difference between the 2 groups. These findings suggest that the addition of azithromycin to the chemotherapy regimen resulted in improved survival outcomes for patients with non-small cell lung cancer. Similar results were observed with clarithromycin in a randomized study, involving 49 consecutive patients with unresectable primary lung cancer. The study aimed to determine whether clarithromycin could improve patient outcomes. Among the 49 patients who had received prior chemotherapy or radiotherapy, they were randomly assigned to 2 study groups. The clarithromycin group consisted of 25 patients who received oral clarithromycin, at a dose of 400 mg per day, while the non-clarithromycin group consisted of 24 patients, who did not receive clarithromycin. The administration of clarithromycin significantly increased the median survival time for patients with non-small cell lung cancer. The median survival for the clarithromycin group was 535 days, compared to 277 days for the non-clarithromycin group. Throughout the treatment period, no remarkable side effects were observed in the clarithromycin group. The study concluded that long-term treatment with clarithromycin is beneficial for patients with unresectable non-small cell lung cancer, leading to an increase in the median survival of patients with advanced disease. The benefit of clarithromycin was further confirmed in combination with standard care lenalidomide, low-dose dexamethasone. The study was a collaboration between New York Presbyterian Hospital Cornell Medical Center and Mayo Clinic. The objective of this case-matched study was to compare the efficacy and toxicity of the addition of clarithromycin to lenalidomide low-dose dexamethasone, so-called BI-RD protocol, versus lenalidomide low-dose dexamethasone, RD, for newly diagnosed myeloma. Data from 72 patients, treated at the New York Presbyterian Hospital Cornell Medical Center, were retrospectively compared, with an equal number of matched pair mates, selected among patients seen at the Mayo Clinic who received RD. Case matching was blinded. On intention to treat analysis, complete response 45.8% versus 13.9% were significantly higher with BI-RD. Time to progression, median 48.3 versus 27.5 months, and progression-free survival median 48.3 versus 27.5 months were higher with BI-RD. There was a trend toward better overall survival, with BI-RD 89.7% versus 73.0% for RD. Results of this case-matched analysis suggest that there is significant additive value when clarithromycin is added to RD. Now I would like to share with you the remarkable findings of a groundbreaking study conducted by esteemed scientists from UT Dallas. The study focused on evaluating the effects of itraconazole, a medication commonly used in clinical practice, on patients diagnosed with non-small cell lung cancer who were scheduled for surgical resection. A cohort of 13 patients actively participated in this study. They were administered an oral dosage of 300 mg of itraconazole, twice daily, for a duration of 10 to 14 days. The researchers were pleased to report that the patients demonstrated excellent tolerance to the medication, enhancing the overall feasibility of this therapeutic approach. The study's observations revealed a fascinating discovery, a noteworthy six-fold variation in itraconazole concentrations across the patients. Interestingly, the concentration of itraconazole within the tumors followed a similar trend to that in the plasma, but intriguingly surpassed it. This significant finding suggests the potential of itraconazole to accumulate within the tumor tissues, paving the way for targeted therapeutic benefits. Furthermore, the researchers uncovered compelling correlations between higher levels of itraconazole in the patient's system and a multitude of positive outcomes. These included a remarkable reduction in tumor volume, decreased tumor perfusion, lowered levels of pro-angiogenic cytokines, which facilitate blood vessel formation, and a decrease in tumor microvessel density. Additionally, the tumors treated with itraconazole displayed distinct metabolic profiles, distinguishing them from their untreated counterparts. In conclusion, these extraordinary findings underscore the concentration-dependent early anti-vascular, metabolic, and anti-tumor effects of itraconazole. The study not only contributes valuable insights into the potential therapeutic benefits of itraconazole, but also paves the way for its optimization in the management of cancer. These discoveries hold tremendous promise for improving patient outcomes and fostering advancements in the field of cancer treatment. A randomized, Phase 2 study conducted by doctors from Johns Hopkins University aimed to assess the efficacy of oral itraconazole at different doses in men with metastatic prostate cancer. The study included 46 men who had not received chemotherapy before and had metastatic castration-resistant prostate cancer, CRPC. These participants were randomly assigned to receive either a low dose, 200 mg per day, or a high dose, 600 mg per day, of itraconazole, until disease progression or unacceptable side effects. After 6 months, the study evaluated the prostate-specific antigen progression-free survival rates, PPFS. The results showed that in the low-dose group, the PPFS rate was 11.8%, while in the high-dose group, it was 48.0%. The study also observed a PSA response rate of 14.3%. Additionally, itraconazole demonstrated favorable effects on circulating tumor cell counts and suppressed hedgehog signaling in skin biopsy samples. However, itraconazole did not reduce serum testosterone level or dehydroepiandrosterone sulfate levels. Common side effects included fatigue, nausea, anorexia, rash, and a syndrome characterized by hypokalemia, hypertension, and edema. In conclusion, high-dose itraconazole, 600 mg per day, showed modest anti-tumor activity in men with metastatic CRPC, and this effect was not attributed to testosterone suppression. Itraconazole may be a non-hormonal treatment option for patients with castration-resistant prostate cancer who prefer to delay or avoid chemotherapy. These findings highlight the potential of itraconazole in managing prostate cancer and provide insights for further exploration in this area. A recent and similar study conducted at UCSF examined the use of itraconazole as a potential non-castrating treatment option for patients with earlier stage prostate cancer experiencing only biochemical relapses. These relapses are characterized by an increase in prostate-specific antigen, PSA, levels without visible signs of the disease. The study enrolled a total of 21 patients who had biochemically recurrent prostate cancer and a PSA doubling time, PSADT, of 15 months or less. The primary goal of the study was to determine the proportion of patients who experienced a decline of at least 50% in their serum PSA levels from the baseline by the 12th week of treatment. Among the 19 patients whose data was evaluated, one patient, 5%, showed a decline of more than 50% in PSA levels. However, 9 patients, 47%, experienced some degree of PSA decline, with an average decline of 25.0% by the 12th week of treatment. Interestingly, among the 10 patients who did not experience a decline in PSA levels, there was a significant difference in the PSA-DT during treatment, compared to before treatment, with a median PSA-DT of 6.8 months versus 4.3 months. These findings suggest that itraconazole may have clinical meaningful, although limited effectiveness, in achieving significant PSA reductions in patients with biochemically recurrent prostate cancer. However, further research is needed to explore its potential benefits and optimize its usage in this specific context. This study provides intriguing insights into the interaction between itraconazole and ibrutinib, shedding light on a potentially beneficial effect of this drug-drug interaction. Ibrutinib is a type of targeted cancer drug. It is a treatment for mantle cell lymphoma and chronic lymphocytic leukemia. As we are aware, itraconazole is known for its numerous drug interactions, which have raised concerns regarding its clinical use. However, not all drug interactions have negative consequences. Let us delve into the details of this research. To provide some context, it is important to note that the oral bioavailability of ibrutinib is low and variable. This is primarily due to extensive first-pass metabolism by an enzyme called cytochrome P450, CYP3A4. The unpredictable exposure to ibrutinib can potentially compromise its safe and effective dosing. In a randomized crossover study involving 11 healthy subjects, the impact of itraconazole on the pharmacokinetics of ibrutinib was investigated. The results demonstrated that itraconazole significantly increased the blood concentration of ibrutinib by 10-fold and the peak plasma concentration by 8.8-fold. Additionally, it was observed that the subject-to-subject variation during itraconazole was approximately half of that observed during the placebo phase. In conclusion, this study highlights that itraconazole substantially enhances the bioavailability of ibrutinib and reduces interindividual variability in its pharmacokinetics. These findings offer the potential for improved dosing accuracy and cost savings, indicating a favorable aspect of the itraconazole-ibrutinib drug interaction. Now, I am going to talk about another class of off-label drugs, statins. The history of red yeast rice and statin drugs can be traced back to the late 1970s, when researchers in the United States and Japan were exploring the potential benefits of certain compounds derived from fungi. They isolated lovastatin from the Aspergillus mold, and monocollins from the Monascus mold during their investigations. Interestingly, the Monascus mold is the same fungus used in the production of red yeast rice in China. The study of red yeast rice began when Dr. Endo examined over 6,000 compounds isolated from a rice sample collected at a grain shop in Kyoto. Among these compounds, one was identified as a statin, which would later become an essential class of cholesterol-lowering drugs. Red yeast rice is a type of fermented rice that obtains its distinctive reddish-purple color from being cultivated with the Monascus purpureus mold. This food preparation tradition dates back to approximately 300 BC in China. Aside from its culinary applications, red yeast rice has a history of use in Chinese herbology and traditional Chinese medicine. The modern use of red yeast rice as a dietary supplement emerged in the late 1970s, when researchers discovered its connection to lovastatin and monocollins. Subsequently, red yeast rice became available as a non-prescription dietary supplement in the United States and other countries. However, in 1998, the U.S. Food and Drug Administration, FDA, took steps to regulate red yeast rice products containing monocolin K as a drug. The FDA argued that these products were identical to prescription drugs, therefore should be subject to regulation. In addition to its use as a dietary supplement, red yeast rice continues to be utilized in traditional Chinese medicine. It is believed to have properties that promote blood circulation and alleviate stasis, as stated by Li Shizhen, a renowned figure in Chinese herbology. Overall, the history of red yeast rice and statin drugs reveals a fascinating journey of scientific discovery and traditional practices. Statin drugs can be classified into two categories, based on their solubility properties: lipophilic statins and hydrophilic statins. Lipophilic statins. Lipophilic statins have a high affinity for fat or lipid-based substances. They are more soluble in lipids than in water. Examples of lipophilic statins include atorvastatin, simvastatin, and lovastatin. These statins can penetrate cell membranes easily, due to their lipophilic nature, which allows them to target cholesterol synthesis within cells. Hydrophilic statins. Hydrophilic statins, on the other hand, have a higher water solubility than lipids. They are less likely to accumulate in fatty tissues, and have a greater affinity for plasma proteins. Hydrophilic statins include rosuvastatin and pravastatin. These statins are primarily metabolized in the liver, and are less prone to drug-drug interactions than lipophilic statins. Lipophilic statins have shown greater potency as anti-cancer agents than hydrophilic statins, primarily due to their improved ability to permeate cell membranes. To effectively suppress the enzyme HMGCR, 3-hydroxy-3-methylgluteryl coenzyme A reductase, which is involved in cholesterol synthesis, a long half-life statin, and appropriate dosing intervals are crucial. This ensures that mevalonate resynthesis, a process dependent on HMGCR, remains suppressed consistently between drug doses. Achieving cytotoxic concentrations in cancer cells typically requires higher doses of statins, compared to those used for treating hypercholesterolemia. Among the statins, pitavastatin is the most promising anti-cancer agent due to its lipophilicity, potency, and relatively long half-life. Statins have been investigated for their potential anti-cancer properties. They work through a few notable mechanisms. Cholesterol depletion. High cholesterol levels have been linked to several types of cancer. By lowering cholesterol, statins can disrupt cancer cell membranes and signaling, inhibiting cancer cell growth and proliferation. Mevalonate pathway inhibition. The mevalonate pathway is essential for producing many substances in the cell, including cholesterol and other non-sterol isoprenoids, such as geranyl geranyl pyrophosphate, GGPP, and farnyl pyrophosphate, FPP. These substances are crucial for the post-translational modification and function of small GT polysaccharide like RAS, RHO, and RAC, which play essential roles in cell proliferation, survival, and migration. By inhibiting the mevalonate pathway, statins can disrupt these processes, potentially suppressing cancer progression. Regulation of autophagy and induction of ferroptosis. Autophagy is a process that cells use to recycle their components, and it can be both beneficial and detrimental in cancer. On the one hand, it can help cells survive under stress, nutrient deprivation, and hypoxia, but on the other hand, excessive autophagy can lead to cell death. Statins can regulate this process, potentially leading to cancer cell death. Similarly, ferroptosis is a type of cell death associated with iron and lipid peroxidation, and statins may promote this process in cancer cells. Modulation of tumor microenvironment, TME. The TME, which includes all the non-cancer cells in a tumor, like immune cells, fibroblasts, and blood vessels, can significantly influence cancer progression. It's suggested that statins may alter the TME in ways that are unfavorable to cancer growth, although the exact mechanisms are still being studied. As for the cancers sensitive to statin treatment, some studies have suggested that ER-negative breast cancers, multiple myelomas with specific chromosomal translocations, and cancers with p53 or VHL mutations, might be more susceptible. However, these findings need further validation in clinical trials. Now, let us focus on one of the most promising statins, pitavastatin. In a study conducted by researchers at the University of California, a collection of FDA-approved compounds was screened to identify new potential therapies for glioblastoma multiforme, GBM, a type of brain tumor. The screening process utilized a variety of human GBM lines, including patient-derived primary GBM lines that have significant clinical relevance. The screening revealed 22 compounds from various classes that exhibited antineoplastic activity in GBM. Among these, statins displayed high efficacy in reducing tumor growth. Further investigation demonstrated the superior effectiveness of a specific statin, pitavastatin, compared to other statins. Moreover, the study found that combining pitavastatin with low-dose chemotherapy substantially enhanced the potency, without significantly increasing adverse effects. The researchers observed that statins triggered autophagy, a process of self-degradation and recycling of cellular components, in GBM. Additionally, they discovered that statins might enhance the effectiveness of chemotherapeutic agents by inhibiting the function of MDR1, a protein known to contribute to drug resistance in cancer cells. Now, I would like to share with you some of the clinical studies using statins in cancer. The SPECTRE study offered the first piece of evidence showcasing the effects of statin treatment on castration-resistant prostate cancer, demonstrating preliminary indications of disease stabilization. Prior to the study, all patients exhibited similar prostate-specific antigen, PSA, velocity rates. However, following atorvastatin treatment, half of the participants, 6 out of 12, experienced a decrease in their PSA velocities, which suggests potential disease stabilization. Clinical research analyzing data from 15,422 patients, diagnosed with hepatocellular carcinoma, HCC, between 2002 and 2016, registered in the VA Central Cancer Registry, revealed a correlation between post-diagnosis statin use and reduced mortality rates in HCC patients. Specifically, those patients who began using statins after their HCC diagnosis demonstrated a 15% lower risk of cancer-specific mortality, compared to those who did not use statins. Now, I would like to show you another important clinical study. The TOHO lipid intervention trial using pitavastatin, TOHO-LIP, was a multicenter, open-label, randomized controlled trial, designed to compare the effects of pitavastatin and atorvastatin directly. The trial involved 622 patients with hypercholesterolemia. Results indicated that pitavastatin, 2 mg per day, was more effective than atorvastatin 10 mg per day, in preventing the primary endpoint, which was cardiovascular death. In addition to this, the trial suggested a potential anti-cancer effect of pitavastatin. Over a cumulative 240-week period, the incidence of new cancer cases was found to be lower in the pitavastatin group compared to the atorvastatin group, 0.32% versus 1.94%. These findings suggest that pitavastatin might not only be superior to atorvastatin in terms of managing hypercholesterolemia and preventing cardiovascular events, but it might also be more effective in preventing cancer. While liver toxicity can occur in individuals using statins, it is relatively rare, and with careful monitoring and management, statins are generally considered safe. Here's how to manage potential liver toxicity in statin users. If transaminase levels are elevated to between 1 and 3 times the upper limit of normal, ULN, but the individual shows no symptoms, it's typically safe to continue statin therapy. However, it is crucial to closely monitor liver function through regular testing. If transaminase levels rise to more than 3 times the ULN, it might be necessary to adjust the statin therapy. This can include reducing the statin dose or, in some cases, discontinuing statin therapy. During this period, it's also important to explore other potential causes of the elevated liver enzyme levels. Now, let's turn our attention to metformin, a fascinating drug that has sparked significant research interest. Like many drug repurposing initiatives, the focus on metformin occurred somewhat by chance. Around 2 decades ago, scientists examining the metabolic effects of metformin in diabetic patients discovered that it inhibits complex 1, which is one member of the mitochondrial respiratory transport chain. This inhibition consequently leads to activating AMP-activated protein kinase, AMPK. AMPK is a known tumor suppressor. It controls various downstream anabolic pathways that are crucial for tumor cell growth. Additionally, researchers from Harvard have revealed that metformin selectively targets and eradicates cancer stem cells in 4 genetically diverse types of breast cancer. However, the exact mechanism by which metformin operates within tumor cells remains a topic of ongoing debate. Further preclinical studies suggest that metformin exerts numerous pleiotropic effects on cancer cells. Still, it's plausible that most, if not all, of these effects are downstream consequences of metformin's inhibition of complex 1 and subsequent activation of AMPK, rather than the drug interacting with multiple targets. In addition to these effects, metformin has been shown to inhibit AKT-mTOR signaling and suppress fatty acid synthesis. Metformin seems to influence nearly all known hallmarks of cancer, bolstering its potential as a robust anti-cancer agent. The MANSOM study, a recent single-blinded, randomized trial, evaluated the impact of adding metformin to standard combined hormone treatment in men with either high-risk localized prostate cancer or metastatic castration-sensitive prostate cancer. The findings indicated a notable prolongation in the time to castration-resistant disease in patients receiving metformin, with a median of 29 months, compared to 20 months in those administered a placebo. This difference being statistically significant, p equals 0.01. This effect was particularly noticeable in patients with high-risk localized disease and node-positive disease. However, with the current follow-up duration, there was no discernible difference in overall survival. The study concluded that metformin, a safe and low-cost drug, may potentially enhance outcomes in locally advanced or metastatic prostate cancer when combined with androgen deprivation therapy, particularly in patients with low-volume metastatic prostate cancer. This is another very important study published in JAMA Oncology. The study revealed that the progression-free survival, PFS, of patients with EGFR-mutated lung adenocarcinoma can be significantly extended by supplementing tyrosine kinase inhibitor, TKI, treatment with metformin. TKI is one of the standard care treatments for lung cancer. The study involved 139 participants, all of whom were administered standard doses of EGFR TKI, including erlotinib, afatinib, or gefitinib. Among these patients, 69 also received metformin 500 mg twice daily. At the median follow-up time of 16.9 months, patients receiving a combination of EGFR TKI and metformin together showed a median PFS of 13.1 months. This was notably longer than the 9.9-month median PFS observed in those treated with EGFR TKI alone. This indicates that adding metformin to the treatment regimen can decrease the risk of disease progression or death by 40%, as explained by the research team. Furthermore, the group taking metformin had a significantly extended median overall survival at 31.7 months, compared to 17.5 months in the non-metformin group. There was also a higher objective response rate of 71.0% versus 54.3% in patients treated with metformin. How about metformin and chemotherapy for lung cancer? Okay, let's now examine the impact of metformin on lung cancer, when combined with chemotherapy. The study conducted at Johns Hopkins was an open-label, single-center phase 2 trial. It involves patients with advanced or metastatic non-small cell lung cancer, who had not undergone chemotherapy before. These patients were divided into two groups. One group was treated with carboplatin, paclitaxel, and bevacizumab along with metformin, while the other group received the same treatment but without metformin. This regimen lasted for 4 to 6 cycles, followed by a maintenance therapy phase involving bevacizumab, either with or without metformin, and continued until the disease progressed. The study enrolled a total of 25 patients. Among them, those in the chemotherapy plus metformin group showed a 1-year progression-free survival rate of 47%, significantly higher than the 15% historical control rate. The median overall survival duration, for patients in the chemotherapy plus metformin group, was 15.9 months, compared to 13.9 months in the chemotherapy alone group. The study observed no significant discrepancies, in terms of toxicity between the two groups. This research is the first of its kind, to demonstrate a significant improvement in the progression-free survival rate, among this patient group on chemotherapy and metformin, attributed to the use of metformin. It points towards the potential effectiveness of metformin, in the treatment of advanced non-small cell lung cancer. 2 comprehensive studies conducted by leading research institutions, such as MSKCC, MD Anderson, Duke, and Harvard, involving a substantial cohort of more than 2,000 patients, provided insightful results regarding the use of metformin in cancer treatment. The prostate-specific antigen, PSA, response rate was notably higher in patients administered metformin, with a response rate of 41%, as opposed to a 28% response rate observed in the control group not receiving metformin. In terms of survival rate, both metformin and statin treatments resulted in a 30% improvement, demonstrating their potential benefits in cancer therapy. In conclusion, while acknowledging the inherent limitations of post-hoc subanalyses, it can be said that both metformin and statins are associated with prolonged overall survival and an increased PSA response. This correlation seems particularly pronounced when these drugs are administered in combination with standard of care, like androgen deprivation therapy or anti-androgen therapy. Now let's turn our attention to another significant facet of metformin, its potential to improve the quality of life and decrease the side effects of chemotherapy. This was demonstrated in a phase 3 trial for breast cancer. In this trial, when metformin was added to the standard ACT chemotherapy regimen, the results were quite remarkable. The patients who received metformin experienced significantly less severe peripheral neuropathy, oral mucositis, and fatigue. But the benefits of metformin didn't stop here. The study also found that the incidence of fatty liver was significantly lower in the group receiving metformin compared to the control group. Furthermore, the hematological disturbances, often caused by ACT chemotherapy, were effectively managed when metformin was given concurrently. In essence, what these findings suggest is that metformin presents a compelling therapeutic opportunity to mitigate the side effects caused by chemotherapy. This is especially relevant for non-diabetic patients with breast cancer, opening a new avenue of possibilities in their treatment regimen. We have thus far considered several early trials of metformin as a potential cancer treatment. These studies have shown encouraging results, though they are often limited by small sample sizes, making the results less certain. Regrettably, the outcomes from larger Phase 3 trials, which encompass randomized studies across various contexts, have not consistently demonstrated substantial clinical benefits when metformin is used as a standalone treatment for cancer. A key example of this is the MA32 study in breast cancer. This large Phase 3 trial recruited over 3,600 patients with high-risk operable breast cancer, who were randomly assigned to receive either 850 mg of metformin or a placebo for 5 years. The study's conclusions were clear: the addition of adjuvant metformin did not improve disease-free survival rates for either estrogen receptor-positive or estrogen receptor-negative breast cancer. However, by carefully looking at the data, there could be a small benefit in ER-negative patients. Furthermore, a secondary analysis did hint at a potential advantage for patients with HER2-positive breast cancer, although this needs further investigation. Despite these overall disappointing results, the exploration of metformin in cancer treatment should not be abandoned. New research directions that may prove fruitful include examining the combination of metformin with immunotherapy, its inclusion in a multi-drug regimen as part of standard cancer treatments, and its potential preventive role against cancer. Each of these promising areas deserves further, well-designed clinical research. Let's shift our focus to pioglitazone, another different medication approved by the FDA for the treatment of type 2 diabetes. Pioglitazone's potential extends beyond diabetes management, as it emerges as a promising candidate in cancer treatment strategies. Pioglitazone belongs to a group of antidiabetic medications, called thiazolidinediones, or TZD in short. Notably, there is growing evidence suggesting that TZD may possess anti-carcinogenic properties. The mechanism behind the potential anti-cancer effects of TZD lies in their interaction with peroxisome proliferator activated receptors PPAR. PPAR are nuclear hormone receptors, including PPAR alpha, PPAR delta, and PPAR gamma, which play a crucial role in regulating various cellular processes related to cancer, such as cell proliferation, survival, apoptosis, and tumor growth. TZD can induce apoptosis, inhibit cancer cell proliferation, by reducing the expression of certain key proteins, like c-Myc, BCL2, VEGF, and BFGF. In addition, TZD can lead to intracellular calcium depletion and proteasome degradation, triggering cell cycle arrest. They can also inhibit the transcription of hormone receptors involved in cancer and reduce macrophage activation, thereby helping to control inflammation. Collectively, the evidence is increasingly suggesting that pioglitazone could open up a new frontier in the battle against cancer. In recent preclinical investigations, the potential of TZD in targeting chronic myeloid leukemia stem cells has been demonstrated. These studies exhibited a reduction in STAT5 transcription, suggesting a promising avenue for therapeutic intervention. Building upon these findings, the ACTIM Phase 2 clinical trial was conducted to assess the impact of pioglitazone, when added to imatinib, on residual disease of chronic myeloid leukemia, as determined by BCR-ABL1 transcript quantification. For your reference, imatinib is the standard care for chronic myeloid leukemia. During the trial, chronic myeloid leukemia patients were administered pioglitazone, at a daily dosage ranging from 30 to 45 mg, in addition to their imatinib regimen. The study enrolled a total of 24 patients, and no pharmacological interactions were observed between the two drugs. The cumulative incidence of achieving a complete molecular response reached 56% within 12 months. Furthermore, among the 17 patients, who were still receiving imatinib at the 48-month mark, an impressive 88% attained complete molecular response. It is noteworthy that in a parallel cohort of patients treated solely with imatinib, the estimated cumulative incidence of complete molecular response over 12 months was just approximately 23% only. Here you saw the difference of 56% versus 23% in complete response. The combination of pioglitazone and imatinib exhibited favorable tolerability, and yielded a noteworthy complete molecular response rate of 56%. These findings provide encouraging evidence for the potential of pioglitazone as an adjunct therapy for chronic myeloid leukemia. Further research and exploration in larger patient populations are warranted to validate and expand upon these outcomes. During this Phase 2 trial evaluating the potential of pioglitazone as an adjuvant therapy for acute myeloid leukemia, a randomized clinical study was conducted. Newly diagnosed acute myeloid leukemia patients were divided into two groups, with both groups receiving standard care consisting of cytarabine and daunorubicin. In addition to this standard treatment, patients in the pioglitazone group were administered oral pioglitazone at a daily dosage of 45 mg. The primary objective of the study was to assess the complete remission rate as an indicator of treatment efficacy. Upon evaluating a total of 40 patients, it was found that the pioglitazone group exhibited a 20% higher complete remission rate compared to the control group. Although this difference did not reach statistical significance, it could still hold clinical importance. Notably, the addition of pioglitazone to the standard treatment regimen did not result in any serious adverse events, demonstrating its favorable safety profile. These findings suggest that pioglitazone may offer benefits as an adjuvant therapy, and further research is warranted to validate and explore its full potential. Now, we are going to move to an important class of medicine, the COX inhibitors. Cyclooxygenase, or COX, is an essential enzyme involved in the production of prostanoids, including prostaglandins, prostacyclins, and thromboxanes. These substances, known as prostanoids, play a crucial role in the inflammatory response. There are two known COX enzymes, COX-1 and COX-2. COX-1 primarily generates prostaglandins that protect the gastrointestinal mucosa, while COX-2 produces prostaglandins involved in inflammation and pain throughout the body. By selectively inhibiting COX-2, certain medications, known as selective COX-2 inhibitors, can alleviate inflammation-related pain, without causing harm to the gastrointestinal mucosa. In comparison, commonly used NSAID, like ibuprofen and naproxen, typically affect both COX-1 and COX-2 enzymes. Consequently, these medications are referred to as non-selective NSAID. Selective NSAID, on the other hand, more precisely target the COX-2 enzymes, thus earning the name selective NSAID. Among the selective COX-2 inhibitors, celecoxib, sold under the brand name Celebrex, is the only medication available in the United States. COX inhibitors, including both non-selective and selective NSAID, are widely used due to their analgesic, pain-relieving, anti-inflammatory, and antipyretic, fever-reducing properties. They find application in various conditions and diseases, such as osteoarthritis, rheumatoid arthritis, musculoskeletal injuries, spondyloarthritis, migraines, and colon cancer, specifically aspirin. So, let's talk about how COX-1 and COX-2 inhibitors affect cancer. Prostaglandins and thromboxane are these lipid signaling molecules that come from arachidonic acid, thanks to the action of these enzymes called cyclooxygenases, or COX-1 and COX-2. Now, the role of these cyclooxygenases, especially COX-2, and prostaglandins, specifically PGE2, in cancer-related inflammation, has been studied quite a bit. Interestingly, COX-1 and COX-2 seem to work together in cancer, particularly when it comes to the process of tumorigenesis. Now, COX-1 hasn't received as much attention, but we're finding that its expression actually increases in various human cancers, suggesting it plays a role in cancer development. In some cases, like with serous ovarian carcinoma, COX-1 is pretty important. So, when it comes to cancer, COX-1 seems to have a pathophysiological role that's consistent and coordinated with COX-2. Now, let's talk about PGE2. It has an impact on tumor initiation and growth. It does this by turning off certain tumor suppressor and DNA repair genes through a process called DNA methylation. PGE2 actually increases the expression of DNMT1 and DNMT3B, which are enzymes involved in DNA methylation. Additionally, PGE2 promotes the formation and expansion of cancer stem cells. It does this by activating a pathway called NF-kappa B through the EP4, PI3, MAPK pathways. So, understanding how COX-1, COX-2, and PGE2 are involved in cancer gives us some insight into potential targets for treatment. COX-2 inhibitors have been studied quite extensively and show promise in certain cancers. Now, let's take a closer look at a specific COX-1 inhibitor, indomethacin. In a randomized Phase 2 study, a group of patients with solid tumors, a total of 135 patients, were split into different treatment groups using a computer-based algorithm. Some received a placebo, while others were given prednisolone 10 mg twice daily or indomethacin 50 mg twice daily orally. Interestingly, the patients treated with indomethacin or prednisolone maintained their performance status, meaning they didn't experience a decline in their overall functioning. In contrast, the patients in the placebo group did show decreased performance. Furthermore, the indomethacin-treated patients reported experiencing less pain, and requiring fewer additional pain-relieving medications than the other groups. But here's where it gets even more interesting. The mean survival time for patients in the placebo group was 250 days. However, indomethacin treatment significantly prolonged the average survival to 510 days. When all the patients treated with either indomethacin or prednisolone were analyzed together, the survival analysis showed that the anti-inflammatory treatment resulted in significantly longer survival, compared to the placebo group. These findings suggest that COX-1 inhibition, in this case with indomethacin, not only provided palliative support to patients with advanced solid cancers, but also influenced pathways that can ultimately impact overall outcomes. So, it appears that targeting COX-1 with indomethacin could have positive effects on both the quality of life and survival of patients with solid tumors. Let's take a look at another clinical trial involving a COX inhibitor, specifically meloxicam, and its potential to reduce recurrence in hepatocellular carcinoma, HCC. In HCC, the enzyme cyclooxygenase 2, or COX-2, is overexpressed. So, in this study, 232 patients who underwent hepatic resection, or microwave ablation, as their initial therapy were included. Of these patients, 224 were randomly assigned to either a control group, or a meloxicam group. In the meloxicam group, the patients received a daily dose of 15 mg, divided into 3 doses of 5 mg each. Now, let's look at the results. The 5-year overall survival rates in the meloxicam group were 70.1%. On the other hand, the control group had a 5-year overall survival rate of 71.5%. The corresponding disease-free survival rates for the meloxicam group were 44.0%, while for the control group it was 43.4%. So you can see there were no difference between meloxicam group and control group. However, when looking at the subgroup analysis of patients without viral hepatitis, significant differences were observed in the disease-free survival rates. Specifically, the 3-year disease-free survival rate for the meloxicam group was 75.8%, whereas for the control group it was 48.1%. These findings suggest that, while there were no significant differences in overall disease-free survival rates between the meloxicam group and the control group as a whole, when focusing on patients without viral hepatitis, there was a notable improvement in the disease-free survival rate with the use of meloxicam. Let's talk about another COX-2 inhibitor called celecoxib, or Celebrex by its brand name, and its role in preventing colon cancer recurrence. Celebrex is a newer COX-2 inhibitor. In a study conducted, a total of 2,526 patients with stage 3 colon cancer participated. These patients were randomly assigned to receive adjuvant FOLFOX treatment for either 3 months or 6 months. Additionally, some patients received 3 years of celecoxib at a daily oral dose of 400 mg, while others received a placebo. Now, let's look at the results. The 3-year disease-free survival rate for patients treated with celecoxib was 76.3%, while for those in the placebo group, it was 73.4%. Furthermore, the 5-year overall survival rate for the celecoxib group was 84.3%, whereas, for the placebo group, it was 81.6%. Although the differences between the two groups are minimal, there seems to be a consistent trend, indicating some improvement with the use of celecoxib. Celecoxib in combination with chemotherapy was also studied in late-stage metastatic colon cancer. The results from this study were more encouraging. When celecoxib was used alongside chemotherapy, called FOLFIRI, it showed a significant increase in the objective response rate, compared to the group that received FOLFIRI alone. Not only that, but the group that received celecoxib with FOLFIRI also had significantly higher progression-free survival, and 1-year overall survival, compared to the FOLFIRI-only group. However, we need to interpret these trial results carefully. It's worth noting that the control group, which received FOLFIRI alone, had a median survival of only 8 months, which is considerably lower than the average for the overall patient population. Now, let's explore 2 more studies that investigate the use of COX-2 inhibitors in combination with novel low-dose chemotherapy. The first trial focuses on children with solid tumors. It was a prospective, open-label, single-arm, multi-institutional Phase 2 study, conducted by Dana-Farber Cancer Institute, affiliated with Harvard Medical School, aimed at evaluating the effectiveness of a 5-drug oral regimen in children with recurrent or progressive cancer. In this study, patients who were 21 years old or younger, and had recurrent or progressive tumors, were eligible to participate. The treatment consisted of continuous oral administration of celecoxib, thalidomide, and fenofibrate, combined with alternating 21-day cycles of low-dose cyclophosphamide and etoposide chemotherapy. A total of 101 patients were enrolled, and 97 of them began the treatment. The median age of the patients was 10 years. Overall, the treatment was well tolerated, with the most common side effects being related to blood cell counts. Out of the patients, 25% were able to complete 27 weeks of therapy without disease progression. The best treatment responses observed were complete response in 1 patient with medulloblastoma, partial response in 12 patients, stable disease in 36 patients, and progressive disease in 47 patients. In conclusion, the 5-drug regimen was generally well tolerated, and it showed clinical activity in some of the tumors studied. However, it is important to note that the treatment did not demonstrate consistent effectiveness across all tumor types. Nonetheless, this study is important, because it suggests low-dose oral chemotherapy, combined with non-toxic off-label medicines, could provide some real clinical benefits for patients with refractory cancers. Now, let's discuss another COX-2 inhibitors, rofecoxib and etarocoxib. Vioxx is the brand name of rofecoxib. In September 2004, Merck voluntarily withdrew Vioxx. Etarocoxib was not FDA approved in the USA. Both COX-2 inhibitors, rofecoxib and etarocoxib, were examined in the context of low-dose chemotherapy for prostate cancer. The treatment regimen involved low-dose chemotherapy with capecitabine, given at a dosage of 1 gram twice daily, along with dexamethasone at a daily dosage of 1 mg for 14 days every 3 weeks. In addition, COX-2 blockade was implemented, using rofecoxib at a dosage of 25 mg, or etarocoxib at a dosage of 60 mg daily, combined with pioglitazone at a dosage of 60 mg daily until disease progression. A total of 36 consecutive patients with metastatic, castration-resistant prostate cancer were enrolled in this study. Among the 15 patients who demonstrated a prostate-specific antigen response of more than 50%, 9 showed an objective response. The median time it took to observe a PSA response was 2.4 months. 2 of the 9 patients who responded with a PSA level below 4 Ing per milliliter showed complete resolution of skeletal lesions after 9 and 16 months, respectively. Additionally, 13 patients experienced a stable course of the disease, while 5 exhibited progressive disease. The median progression-free survival was 4.0 months, and the median overall survival was 14.4 months. In conclusion, this innovative combination therapy approach, with 2 off-label medicines and low-dose chemotherapy, demonstrated significant responses, including the resolution of skeletal lesions, in patients with castration-resistant prostate cancer. Next, I would like to draw attention to the unique property of certain non-selective COX inhibitors, such as diclofenac, in reducing lactic acid levels. Voltaren XR and Cataflam are the brand names of diclofenac. While the anti-cancer effects of NSAID have primarily been attributed to their inhibition of COX enzymes, there are additional COX-independent mechanisms through which NSAID exert their effects, including the inhibition of tumor cell proliferation and induction of apoptosis. Compelling evidence suggests that elevated lactate levels are associated with poor survival and the evasion of immune surveillance in cancer. More recently, diclofenac, a non-selective COX inhibitor with preferential activity against COX-2, has been discovered to significantly reduce lactate production. Although the exact mechanism has yet to be directly proven, diclofenac is believed to act through a new, COX-independent pathway to restrict lactate production. This is evident as acetylsalicylic acid, or aspirin, primarily a COX-1 active substance, and celecoxib, a selective COX-2 inhibitor, do not affect lactate formation. In highly proliferative tumors like malignant gliomas, lactate formation is associated with poor survival and suppresses local immunity. Interestingly, diclofenac, when used at non-toxic concentrations, has shown the ability to decrease lactate production in murine glioma cells, and inhibit the expression of lactate dehydrogenase, or LDH. Furthermore, animal studies have demonstrated that diclofenac treatment reduces intratumoral lactate levels, and significantly delays glioma growth. Further analysis has revealed that tumor-infiltrating dendritic cells regain their ability to produce interleukin-12 upon diclofenac treatment. Additionally, diclofenac decreases the number of tumor-infiltrating regulatory T cells and impairs the upregulation of the T-reg activation marker CD25. In summary, diclofenac emerges as a promising agent for targeting lactate production and mitigating local immune suppression in malignant gliomas. By reducing lactate levels, diclofenac may help counteract tumor growth and promote a more favorable immune environment in these types of tumors. Now, I am going to discuss another medicine, dipyridamole, briefly. Traditionally, dipyridamole is an antiplatelet agent used in stroke prevention. However, scientific research has shown that dipyridamole may have effects beyond platelet inhibition. It has been found to block the pyrimidine salvage pathway in DNA synthesis, which is relevant in cancer therapy. First, I show you some background information. Nucleotides are the building blocks of DNA and RNA. Nucleotides can be synthesized through de novo synthesis and nucleoside salvage. The de novo pathway involves creating nucleotides from amino acids and glucose, while the salvage pathway recovers nucleosides from the breakdown of cell DNA or RNA. In contrast to highly proliferating non-malignant cells that heavily rely on de novo synthesis, cancer cells have the ability to switch to the nucleoside salvage pathways to ensure efficient DNA replication. Nucleoside transporters are transmembrane proteins. Nucleoside transporters play a vital role in the import and export of free nucleosides across cell membranes. These transporters are involved in the nucleoside salvage process. Among them, HENT1 and HENT2 are widely expressed on cell membranes in various tissues and are specifically required for pyrimidine transport. What role does dipyridamole play in the nucleoside salvage pathways? It is a blocker of the pyrimidine salvage pathway. It inhibits the HENT1 and HENT2 channels, significantly reducing the influx of nucleosides and nucleotides through the salvage pathway. Furthermore, dipyridamole has been found to increase autophagic markers by interfering with the normal maturation of autophagosomes. This disruption of autophagic flux impairs the recycling of cellular components, leading to a decrease in intracellular ATP levels in cancer cells. Moreover, dipyridamole has shown inhibitory effects on statin-induced SREBP activation and enhances apoptosis, further contributing to its potential anti-cancer properties. Sterol regulatory element binding proteins, or SREBP, are crucial regulators of lipid metabolism and act as a protective mechanism that promotes the malignant proliferation of tumor cells. Following treatment of cancer cells with statin drugs, a majority of the cancer cells initiate a feedback response, mediated by sterol regulatory element binding protein 2, leading to the further upregulation of HMGCR, and rendering statins less effective. However, dipyridamole can be utilized to inhibit statin-induced SREBP activation and enhance apoptosis in statin-insensitive cancer cells. Standard chemotherapy drugs, like 5-fluorouracil, 5-FU, primarily target the pyrimidine de novo synthesis pathway. Therefore, a promising strategy is to co-target both the pyrimidine de novo synthesis and salvage pathways. Therefore, understanding the intricate pathways involved in nucleotide synthesis and salvage is essential for developing effective therapeutic approaches. Dipyridamole, with its ability to block the pyrimidine salvage pathway, induces autophagic markers, inhibits statin-induced SREBP activation, and potentiate apoptosis, offers insights into potential cancer cell metabolism modulation strategies. Combination therapies that co-target the de novo synthesis and salvage pathways hold promise in improving treatment outcomes and addressing the limitations of current chemotherapy approaches. Let's examine some clinical studies involving dipyridamole in cancer treatment. Dr. Isikoff, an outstanding surgical oncologist from UCLA, conducted a study to explore the potential synergistic effects of combining dipyridamole and 5-fluorouracil in the treatment of patients with stage 2 or 3 unresectable adenocarcinoma of the pancreas. In the study, patients received 5-fluorouracil at a dosage of 200 mg per square meter per day, continuous intravenous infusion for 4 weeks. Mitomycin was given as a 10 mg per square meter intravenous bolus infusion every 6 weeks for a total of 4 doses. Alongside the chemotherapies, dipyridamole was orally administered at a dosage of 75 mg, 3 times daily. The results of the study showed that out of the 50 eligible patients, 27 survived beyond 1 year, resulting in a 1-year survival probability of 54%. The most common treatment-related toxicity observed was stomatitis, and 3 patients experienced reversible hemolytic uremic syndrome. 5 patients experienced grade 4 toxicity, but no treatment-related deaths occurred. These findings suggest that the strategy of dual biochemical modulation, using fluorouracil in combination with mitomycin and dipyridamole, has the potential to improve survival and potentially increase the resectability of localized unresectable pancreatic cancer. Now, I'm going to shift the focus to histamine inhibitors. Histamine plays a crucial role in the body's response to allergens. It is a biologically active substance that enhances inflammatory and immune responses, and acts as a neurotransmitter too. Antihistamines are medications that counteract these effects by blocking or inhibiting histamine receptors. There are several types of histamine receptors in the human body, including H1, H2, H3, and H4. H1 receptors are primarily found in neuronal and nervous system sites. H2 receptors are more related to stomach and digestive function, H3 receptors in the brain, and H4 receptors in organs and bone marrow. H1 and H2 receptors are found in airway tissues, skin tissue, and immune cells. H1 antihistamines are available in 2 main forms, first generation and second generation. While they have similar effects, second generation antihistamines do not cause sedation. Products labeled as non-drowsy typically fall into the second generation category. Research suggests that second generation H1 blockers offer better results compared to first generation, as they provide similar action with reduced sedating effects. Some studies suggest that second generation H1 blockers may also have an immunomodulatory action. This means that they can help regulate the immune response, potentially providing additional benefits beyond their antihistamine properties. Antihistamines demonstrate a broad spectrum of potential anti-cancer benefits. Current preclinical research has revealed diverse mechanisms that might contribute to these effects. These include impeding cell growth, promoting programmed cell death, apoptosis, enhancing sensitivity to radiation, triggering lysosomal cell death, and influencing immune system pathways. Let's explore some clinical studies of H2 inhibitors first, followed by a detailed look at an intriguing H1 inhibitor, loratadine. However, we will kick off with research on cimetidine. Several H2 inhibitors have been investigated in various settings, yielding mixed results. The British Stomach Cancer Group conducted a randomized, double-blind, placebo-controlled trial to assess the impact of cimetidine on the survival of patients with gastric cancer. A total of 442 patients were enrolled in the study. Cimetidine was administered at doses of 400 mg or 800 mg twice a day. The median survival for patients receiving cimetidine was 13 months, while it was 11 months for those in the placebo group. The 5-year survival rate for patients assigned to cimetidine was 21%, compared to 18% for those in the placebo group. Although there were slight improvements observed in survival, the difference did not reach statistical significance. Here's some more uplifting and promising news. In examining another antihistamine, ranitidine, we discover some positive findings. While the initial analysis of all 740 patients revealed no significant effect of ranitidine on colon cancer survival, it was noted that ranitidine indeed improved the survival rate of patients who hadn't undergone blood transfusions. More specifically, ranitidine may extend the survival of patients undergoing curative resection for colorectal cancer, provided they don't receive a perioperative blood transfusion and avoid postoperative infectious complications. In addition, antihistamines can help decrease the side effects caused by chemotherapy. Complications arising from chemoradiotherapy have always been a major concern for both doctors and patients during cancer treatment. To address this issue, a controlled trial was conducted, involving 60 patients with esophageal and cardiac cancers, who were undergoing chemoradiotherapy. These patients were divided into 2 groups. One group received a daily dose of 40 mg oral famotidine, while the other group received a placebo. The results of the study revealed a significant effect of famotidine in reducing the occurrence of thrombocytopenia, low platelet count, compared to the control group. One of the recent notable studies on the immune modulation of antihistamines comes from the MD Anderson Cancer Center. Currently, it is well known that V-domain Ig suppressor of T-cell activation, in short, VISTA, or VISTA, also referred to as PD-1H, functions as a negative regulator of T-cell activation, much like other well-recognized checkpoint molecules such as PD-L1. Immune system modulation is a crucial aspect of antihistamines' role in exerting anti-cancer effects. A significant component influenced by the histamine H1 pathway is VISTA, which has been linked to immune checkpoint blockade resistance in patients undergoing immunotherapy. When individuals are treated with antihistamines, there is a decrease in VISTA expression on tumor-associated macrophages, TAM, thereby transforming the macrophages from an M2 phenotype to an M1 phenotype. This transformation leads to an enhanced immune response against tumors by T cells. The immune modulation carried out by antihistamines plays a vital role in the potential anti-cancer effects of antihistamine treatment, and there is potential for antihistamines to reverse immune resistance. The research data from MD Anderson about H1 blockers is indeed very encouraging. Investigations led by the scientific team at the University of Texas MD Anderson Cancer Center indicate that readily available second-generation anti-H1 medications may play a pivotal role in improving outcomes for cancer patients receiving anti-PD-1/PD-L1 checkpoint inhibitor treatments for various cancer forms. Furthermore, aspirin use was tied to a decreased death rate among patients under immunotherapy. Among the 40 drugs commonly studied, only second-generation antihistamines and aspirin displayed a significant link, with improved survival rates for patients. Crucially, the study highlighted that combining H1 antihistamines with immunotherapy was significantly associated with better overall survival rates. Now, I'm going to dedicate a few minutes to discuss the use of PPIs, or proton pump inhibitors, in the context of cancer treatment. As we know, proton pump inhibitors, or PPI, function by inhibiting the gastric HKAT-pase, leading to a decrease in gastric acid secretion. This action facilitates healing for conditions such as peptic ulcers, gastroesophageal reflux disease, GERD, Barrett's esophagus, and Zollinger-Ellison syndrome. Beyond these roles, PPIs exhibit a noteworthy effect on fatty acid synthase, FASN. FASN is the chief enzyme responsible for synthesizing a fatty acid, called palmitate within cells. This synthesis is crucial for cancer cells, which largely depend on producing new fatty acids for survival. Additionally, FASN, being the only cytosolic enzyme accountable for de novo lipid synthesis, is essential for the viability of cancer cells, and contributes to drug and radiation resistance by augmenting DNA damage repair. Interestingly, PPIs can reduce the activity of the FASN enzyme by binding to and inhibiting its thioesterase domain. This ability gives PPIs a unique property to disrupt the de novo synthesis of fatty acids in cancer cells. Furthermore, an examination of electronic medical records of 6,754 breast cancer patients showed that the use of PPI significantly improved overall survival rates and reduced disease recurrence. Therefore, PPI may be repurposed as anti-cancer drugs, targeting FASN, and aiding in overcoming drug and radiation resistance. The theory that proton pump inhibitors, PPI, can inhibit FASN has been validated through studies involving clinical patients. In a study involving high-risk breast cancer, the use of omeprazole, a PPI, was investigated. Fatty acid synthase, FASN, which is found to be overexpressed in 70% of triple-negative breast cancer cases, and linked to a poorer prognosis, was the focus. Patients were given omeprazole at a dose of 80 mg orally, twice daily for 4 to 7 days, before starting neoadjuvant anthracycline taxane-based chemotherapy, and continued until surgery. A total of 42 patients participated in the study. Before undergoing chemotherapy, most patients, that is, 85%, displayed FASN overexpression. The pathologic complete response rate was 72.4% in patients with FASN overexpression. Notably, omeprazole monotherapy was found to significantly reduce FASN expression. The administration of omeprazole was well tolerated by the patients. The study suggests that FASN is commonly expressed in early breast cancer, and omeprazole can be safely used at doses that inhibit FASN. The addition of omeprazole to neoadjuvant chemotherapy shows promise in achieving a superior pathologic complete response rate. Disulfiram, marketed under the brand name Antabuse, is a fascinating medication, primarily used for treating chronic alcoholism. It functions by inhibiting an enzyme, known as aldehyde dehydrogenase, or ALDH1, which plays a critical role in metabolizing alcohol. The inhibition of this enzyme by disulfiram triggers an adverse reaction when alcohol is ingested, resulting in uncomfortable symptoms that deter further alcohol consumption. Usual dosage: generally, for treating alcohol dependence, disulfiram is administered orally, in doses ranging from 125 to 500 mg once daily in the morning. The initial regimen typically involves a daily dose of 500 mg for the first 1 to 2 weeks, followed by a maintenance dose of 500 mg per day. It's crucial to ensure patients abstain from alcohol for a minimum of 12 hours before commencing disulfiram treatment. Side effects. One of the significant challenges associated with disulfiram use is its potential side effects. Severe reactions. Disulfiram alcohol reaction. This reaction is the most notable adverse effect of disulfiram. Consumption of alcohol while on disulfiram can trigger severe reactions, including symptoms such as flushing, sweating, rapid heartbeat, nausea, vomiting, chest pain, difficulty breathing, and potentially life-threatening complications. Psychosis. Although rare, disulfiram use can sometimes lead to psychosis, which may include hallucinations, delusions, and disordered thinking. Hepatotoxicity. In some cases, disulfiram can cause liver damage, leading to hepatotoxicity. Regular liver function tests are recommended during treatment. Peripheral neuropathy. Long-term use of disulfiram may result in peripheral neuropathy, causing symptoms such as tingling, numbness, and weakness in the extremities. Optic neuritis. Though rare, optic neuritis, inflammation of the optic nerve, is a potential side effect of disulfiram. Common reactions. Some individuals may experience skin rashes or allergic reactions. Disulfiram can cause drowsiness or fatigue in some patients. Erectile dysfunction or impotence has been reported as a potential side effect of disulfiram use. Headaches are a relatively common side effect of disulfiram. Disulfiram may occasionally cause acne or exacerbate existing acne. Some individuals may experience a metallic taste in the mouth while taking disulfiram. ALDH1 is highly expressed in cancer stem cells, and disulfiram's ability to inhibit ALDH1 naturally leads to the hypothesis that it may have anti-cancer properties. Research has shown that this hypothesis holds true, indicating the potential of disulfiram as an anti-cancer agent. Indeed, disulfiram has been investigated for its potential anti-cancer properties, due to its ability to inhibit ALDH1, which is abundantly expressed in cancer stem cells. Cancer stem cells are a small subset of cells within tumors. They possess self-renewal and tumor-initiating capabilities. Targeting cancer stem cells is important in cancer treatment, because they are often resistant to conventional chemotherapy, and are associated with tumor recurrence and metastasis. By inhibiting ALDH1, disulfiram specifically targets cancer stem cells, which are commonly identified using markers such as CD44, CD133, ALDH activity, and CD326. This targeted approach makes disulfiram a potentially effective treatment for cancers with cancer stem cells populations. Disulfiram's anti-tumor effects can be attributed to several mechanisms. Firstly, disulfiram hampers pathways detoxifying reactive oxygen species in cancer cells. Reactive oxygen species is commonly referred as ROS. This leads to an excessive accumulation of ROS, causing cellular damage. The disruption of ROS detoxification pathways is thought to contribute to the cytotoxic effects of disulfiram on cancer cells. Additionally, disulfiram regulates key signaling pathways involved in cell apoptosis, such as NF-kappa B and JNK. NF-kappa B is a transcription factor. It plays a significant role in inflammation, cell survival, and immune response. JNK is a protein kinase that regulates cellular processes, including cell death. By modulating these pathways, disulfiram can promote apoptosis, or program cell death, in cancer cells. Furthermore, disulfiram has been shown to disrupt the cell cycle, suppressing tumor cell growth. By interfering with the normal progression of the cell cycle, disulfiram can induce cell cycle arrest, and prevent cancer cells from dividing and proliferating. Moreover, disulfiram can also control the secretion and release of cytokines. This ability to modulate cytokine secretion contributes to activating the immunogenic cell death, or ICD, signaling pathway. ICD is a form of cell death that triggers an immune response against cancer cells. By activating the ICD pathway, disulfiram can stimulate T cells to attack tumor cells. These mechanisms score the potential of disulfiram in cancer treatment, by targeting cancer stem cells, disrupting ROS detoxification, regulating signaling pathways involved in cell apoptosis, suppressing tumor cell growth, and activating the immune response against cancer cells. Now, let's take a look at an important trial conducted in Israel. The trial examined the use of disulfiram in lung cancer. This trial was a phase 2, multicenter, randomized, double-blinded study that aimed to assess the safety and effectiveness of adding disulfiram to the standard treatment of cisplatin and vinorelbine for a total of 6 cycles. Disulfiram was administered at a dose of 40 mg 3 times a day. In this study, a total of 40 patients were treated for more than 2 cycles, with half receiving disulfiram, and the other half not receiving it. The administration of disulfiram at the dose of 40 mg 3 times daily was well tolerated by the patients. The results showed that the experimental group, which received disulfiram, had a notable increase in survival compared to the control group, 10 months versus 7.1 months. Interestingly, there were only 2 patients who survived long-term, and both of the long-time survivors were in the disulfiram group. Lithium is a commonly used mood stabilizer in the treatment of mood disorders. Typically, it is prescribed at a dosage ranging from 600 to 1800 mg per day, administered orally and divided into 2 to 3 doses throughout the day. While lithium can be effective in managing mood symptoms, it's important to be aware of the potential side effects associated with its use. Common side effects of lithium may include tremor, increased urination, polyuria, excessive thirst, polydipsia, weight gain, diarrhea, vomiting, and drowsiness. However, there are also more serious reactions that can occur with lithium use. These include coma, seizures, ventricular arrhythmia, abnormal heart rhythm, severe bradycardia, slow heart rate, syncope, fainting, unmasking of Brugada syndrome, a heart rhythm disorder, drug reaction with eosinophilia and systemic symptoms, Dress syndrome, goiter, enlarged thyroid gland, and hypothyroidism, underactive thyroid. In addition to its mood-stabilizing effects, lithium has demonstrated potential anti-cancer activity. In summary, lithium is an effective mood stabilizer, but it can cause various side effects, some of which can be serious. Moreover, there is ongoing research exploring the potential anti-cancer properties of lithium. Lithium is a well-established first-line drug used in the clinical treatment of bipolar disorder. It has recently attracted attention for its potential role in cancer treatment. The precise molecular mechanism underlying lithium's effect on cancer is still being actively investigated. However, it is generally believed that the anti-tumor properties of lithium can be attributed to its inhibition of glycogen synthase kinase 3 beta, or GSK3 beta. GSK3 beta is a serine threonine protein kinase that plays a crucial role in regulating various cellular pathways by phosphorylating specific substrates. Emerging evidence suggests that GSK3 beta promotes cancer progression by interacting with key molecules involved in tumor cell survival, proliferation, invasion, and resistance to standard chemotherapy. By inhibiting GSK3 beta, lithium exerts its anti-tumor effects of inhibiting proliferation and migration, and inducing programmed cell death, such as apoptosis. Laboratory studies utilizing cell lines and animal models have demonstrated the potential anti-tumor effects of lithium in specific cancer types, including brain tumor, colon cancer, endothelial cancer, melanoma, osteosarcoma, and leukemia. Limited clinical studies available suggest that lithium may provide survival benefits in certain cases. In an exploratory trial involving 7 patients, all patients were enrolled after experiencing radiological disease progression, and were classified as recursive partitioning analysis class 7, or RPA-7. RPA-7 indicating poor prognosis. Glioblastoma multiforme patients, or GBM, classified as RPA class 7 typically have a median survival duration of approximately 4.9 months. In this trial, patients were administered a clova cocktail, consisting of 4 drugs, cimetidine, lithium, olanzapine, and valproate in combination with temozolomide. Temozolomide is the standard care. After the first recurrence, the median overall survival, OS, was extended to 11.2 months, in patients who received the concomitant clova cocktail with maintenance temozolomide. The treatment regimen was found to be safe and well tolerated, with the most common treatment-related adverse event being grade 1 or 2 somnolence, caused by the antipsychotic drug components of the clova cocktail. One representative case demonstrated a significant reduction in the recurrent tumor size after initiating the clova cocktail treatment. Immunohistochemistry immunostaining performed during the study suggested that the clova cocktail treatment inhibited GSK3 beta activity, confirming the mechanism of action. It is important to note that these findings are based on a small exploratory trial, with a limited number of patients. Further research and larger clinical studies are needed to confirm these results and better understand the efficacy and safety profile of the clova cocktail, particularly in relation to different cancer types and patient populations. Propranolol, originally used for hypertension, has gained attention in cancer repurposing. The usual dose of propranolol is 40 mg taken orally twice a day, with the possibility of dose escalation every 3 to 7 days, up to a maximum of 640 mg per day. Studies have suggested that propranolol may exhibit anti-cancer properties through mechanisms such as vasodilatation, apoptosis, cell death, or inhibition of angiogenesis, formation of new blood vessels. In small clinical trials, propranolol has shown promising effects in breast cancer. It has been found to reduce the expression of Ki67. Ki67 is a marker associated with cell proliferation. Additionally, propranolol has demonstrated the ability to inhibit epithelial mesenchymal transition, or EMT. EMT is a process involved in the formation of metastases, cancer stem cell, and cancer progression. Propranolol promotes the infiltration of T cells, which play a crucial role in the immune response against cancer cells. These findings highlight the potential of propranolol as a repurposed medication in the context of cancer treatment. Now I would like to discuss two medicines, valproic acid and hydralazine. These medicines directly target epigenetic modifications to modulate gene expression patterns, and have shown promising results in the treatment of certain cancers. Epigenetics is a field of study that focuses on how certain modifications can change the way genes are expressed, without altering the DNA structure itself, such as through mutations. Two main types of epigenetic modifications are DNA methylation and histone modification. DNA methylation involves the addition of a chemical group, called a methyl group, to specific regions of DNA, which can influence gene activity. Histone modification, on the other hand, involves changes to the proteins called histones, around which DNA is wrapped, affecting how tightly the DNA is packaged, and thus impacting gene expression. Epigenetic modifications play a crucial role in various biological processes, including development, differentiation, and disease. They help regulate which genes are active, or inactive, in different cell types, and can be influenced by both genetic and environmental factors. Valproic acid has its effects in a couple of ways. One way is by acting on the levels of a neurotransmitter, called GABA, in the central nervous system. GABA is the abbreviation of gamma-aminobutyric acid. Another recent finding is that valproic acid can inhibit an enzyme, called histone deacetylase, or HDAC in short, particularly HDAC1, as well as other HDAC. This histone deacetylase inhibition can potentially increase gene expression that regulates processes like cell death and actions against tumors. Valproic acid is usually prescribed for seizures. The typical starting dosage is usually around 10 to 15 mg per kilogram of body weight per day, but it should not exceed 60 mg per kilogram. If the daily dose goes above 250 mg, it is given in divided doses throughout the day. To treat manic episodes in bipolar disorder, the initial dose is typically 250 mg taken 3 times daily. This dosage may vary depending on the specific situation and individual needs. It's important to note that valproic acid can have serious adverse reactions. Some of these include liver toxicity, hallucinations, suicidal thoughts, psychosis, severe skin reactions like toxic epidermal necrolysis, and Stevens-Johnson syndrome, severe allergic reactions, low sodium levels in the blood, hyponatremia, and associated syndrome, SIADH, pancreatitis, low platelet count, thrombocytopenia, low levels of all blood cells, pancytopenia, high ammonia levels in the blood, hyperammonemia, bone marrow suppression, myelosuppression, abnormally low body temperature, hypothermia, aplastic anemia, bleeding, skin rash, erythema multiforme, polycystic ovarian syndrome, brain changes resembling shrinkage, cerebral pseudoatrophy, encephalopathy, and coma. Stopping the medication suddenly can also lead to withdrawal seizures. Some common reactions that have been reported by patients using valproic acid include headache, abdominal pain, drowsiness, dizziness, low platelet count, thrombocytopenia, weakness, asthenia, nausea and vomiting, diarrhea, tremors, changes in weight, hair loss, alopecia, constipation, mood swings, emotional lability, insomnia, small purple spots on the skin, petechiae, and larger areas of bruising, ecchymosis, depression, skin rash, nervousness, changes in appetite, the elevation of liver enzymes ALT and AST, ringing in the ears, tinnitus, blurred vision, involuntary eye movements, nystagmus, sensitivity to sunlight, photosensitivity, muscle pain, myalgia, and difficulty breathing, dyspnea. Hydralazine is a medication for moderate to severe hypertension. The typical dosage ranges from 10 to 50 mg taken orally 4 times daily. There are some severe reactions that can occur with hydralazine. These include heart attack, severe low blood pressure, low white blood cell count, lupus erythematosus, peripheral neuritis, and hypersensitivity reactions. Some common reactions that have been reported by people taking hydralazine include headache, rapid heart rate, chest pain, palpitations, nausea, vomiting, and diarrhea. Regarding its mechanism in cancer, hydralazine acts as an inhibitor of DNA methyltransferases, DNMT. DNMT are enzymes that are involved in adding methyl groups to DNA, which can affect gene expression. By inhibiting DNMT, hydralazine can potentially impact DNA methylation in cancer cells, leading to changes in gene activity, and potentially influencing cancer progression. In a case series involving patients with myelodysplastic syndrome, MDS, treated in a compassionate manner, the combination of the DNA methyltransferase inhibitor hydralazine and the histone deacetylase inhibitor valproate has demonstrated preliminary efficacy. In this study, the dosage of hydralazine was determined based on the acetylation genotype of the patients. Slow acetylators received a daily dose of 83 mg, while fast acetylators received 182 mg daily. Valproate was administered at a dose of 30 mg per kilogram per day. Both drugs were given on a daily basis until disease progression. The results of the treatment showed promising responses. Out of the patients, 5, or 35.7%, achieved a complete response. The median overall survival was 27 months, indicating a favorable outcome for these MDS patients. Importantly, the combination of hydralazine and valproate was found to be safe and well tolerated in this context. These findings suggest that the combination of hydralazine and valproate holds potential as an effective and safe treatment approach for patients with MDS. A study was conducted involving 14 patients with cutaneous T-cell lymphoma, CTCL, to evaluate the effects of hydralazine and valproate as a treatment regimen. The patients received hydralazine at a daily dose of either 83 mg or 182 mg, depending on their acetylation rate, slow or rapid, along with valproate administered at a total dose of 30 mg per kilogram of body weight, given 3 times a day, in continuous 28-day cycles as part of this Phase 2 study. The results of the study demonstrated a favorable response to the treatment combination. The overall response rate was found to be 71%, with 50% of the patients achieving a complete response, and 21% showing a partial response. The duration of response was measured to be 28 months, indicating a sustained positive outcome in terms of disease control. Additionally, 13 out of the 14 patients reported complete relief from pruritus, a common symptom associated with CTCL. Notably, there were no significant toxicities of grade 3 or 4 observed during the course of the study, suggesting that the treatment combination was well tolerated by the patients. A randomized Phase 3 study, employing a placebo-controlled design, was conducted to assess the impact of adding hydralazine and valproate, HV, to cisplatin topotecan chemotherapy, in 36 patients with advanced cervical cancer. The patients were divided into 2 groups, with one group receiving HV, and the other group receiving a placebo. The dosage of hydralazine for rapid acetylators was 182 mg, while slow acetylators received 83 mg. Valproate was administered at a dose of 30 mg per kilogram of body weight. HV treatment commenced 1 week before chemotherapy initiation, and continued until disease progression. The study results revealed that the group receiving cisplatin topotecan along with HV exhibited 4 partial responses, PRs, whereas only 1 PR was observed in the cisplatin topotecan plus placebo group. The median progression-free survival, PFS, was 6 months for the cisplatin topotecan plus placebo group, while the cisplatin topotecan plus HV group had a median PFS of 10 months. It is important to note that these findings are preliminary and require further validation. Nonetheless, this study is significant, as it represents the first randomized clinical trial, demonstrating a notable advantage in terms of progression-free survival, through the use of epigenetic therapy, specifically the combination of hydralazine and valproate, when compared to one of the currently employed standard combination chemotherapy regimens in the treatment of cervical cancer. In a phase 2 trial involving 37 newly diagnosed glioblastoma patients, valproic acid, VPA, was administered as part of the treatment regimen. The patients received a dosage of 25 mg per kilogram of body weight, divided into 2 daily doses. This treatment was given concurrently with radiation and temozolomide therapy, which are standard treatments for glioblastoma. The results of the trial demonstrated promising outcomes. The median overall survival for the patients reached 29.6 months. The chemotherapy plus VPA protocol resulted in 86% of the patients being alive at 1 year after initiating the therapy, and 56% of the patients remained alive at more than 2 years from the start of treatment. These survival rates represent a significant improvement compared to previous studies, where median survival ranged from 8.6 to 19.3 months. These findings suggest that the addition of valproic acid to the standard treatment regimen for glioblastoma can yield favorable results in terms of overall survival. The prolonged survival observed in this trial indicates the potential benefit of incorporating VPA into the treatment approach for newly diagnosed glioblastoma patients. However, further research and larger clinical trials are necessary to confirm these findings and establish the optimal role of valproic acid in glioblastoma treatment. Notch1 has been identified as a suppressor of tumors in neuroendocrine tumors, NET. Previous laboratory studies using cancer cell lines have indicated that valproic acid, an inhibitor of histone deacetylase, can activate Notch1. Activation of Notch1 has been associated with decreased levels of tumor markers linked to NETs. To delve deeper into this phenomenon, a study was conducted involving 8 patients diagnosed with low-grade NET, specifically carcinoid and pancreatic tumors. These patients received an oral dose of 500 mg of valproic acid twice a day, with adjustments made to maintain the blood concentration of valproic acid between 50 and 100 micrograms per milliliter. Prior to treatment, there was no evidence of Notch1 activity in the tumors of all patients. However, following the administration of valproic acid, the activity of the Notch1 gene increased within the tumors. Out of the 7 evaluated patients, 5 demonstrated improvements in tumor markers. 4 patients achieved stable disease as the best response to the treatment. Overall, the patients tolerated the valproic acid treatment well, and no significant adverse effects were reported. These findings support the notion that valproic acid can induce Notch1 activation, leading to favorable changes in tumor markers associated with NET. This proof-of-concept study aimed to assess the safety and biological effectiveness of adding demethylating hydralazine and the HDAC inhibitor valproate to neoadjuvant doxorubicin and cyclophosphamide treatment in locally advanced breast cancer. The rationale behind this approach was to target the common occurrence of epigenetic alterations in breast cancer. The patients received hydralazine at a dose of 182 mg for rapid metabolizers, or 83 mg for slow metabolizers, along with valproate at a dosage of 30 mg/kg. This treatment regimen commenced 7 days prior to chemotherapy initiation, and continued throughout 4 cycles of doxorubicin and cyclophosphamide. A total of 16 patients were enrolled in the study, and all of them completed the intended treatment. Among these patients, 5, or 31%, achieved a clinical complete response indicating the disappearance of all signs and symptoms of cancer, while 8, or 50%, exhibited a partial response indicating a reduction in tumor size and cancer burden. This resulted in an overall response rate of 81%. None of the patients experienced disease progression during the study period. Of the 15 patients who underwent surgery, 1, or 6.6%, achieved a pathological complete response, indicating the absence of residual tumor. The combination of hydralazine and valproate led to DNA demethylation, inhibition of HDAC, and reactivation of genes in the primary tumors. Furthermore, it appears that the addition of hydralazine and valproate enhances the efficacy of chemotherapy in treating breast cancer. However, it is important to note that this was a proof-of-concept study with a limited number of patients. Epigenetic abnormalities have been implicated in the development of resistance to chemotherapy. As a result, the potential of hydralazine and valproate in treating advanced cancers that have become resistant to chemotherapy was investigated. This study conducted a phase 2 trial, where hydralazine and valproate were added to the ongoing chemotherapy regimen for patients experiencing disease progression. The results of the study demonstrated a clinical benefit in 12 out of 15 patients, that is 80%. Among these patients, 4 showed a decrease in tumor size, indicating a positive response, while 8 patients experienced stable disease. The primary observed side effect was hematologic toxicity. Furthermore, the study revealed a decrease in overall DNA methylation levels, inhibition of histone deacetylase activity, and demethylation of gene promoters. The positive clinical outcomes observed in this study, where patients who were progressing on chemotherapy were treated with hydralazine and valproate, and subsequently rechallenged with the same chemotherapy regimen, provide support for the hypothesis that epigenetic alterations in tumor cells contribute to their resistance to chemotherapy. These findings highlight the potential of targeting epigenetic modifications as a strategy to overcome chemotherapy resistance in advanced cancers. Agents with differentiating properties can potentially modify tumor growth and progression while inhibiting the spread of metastases. Phenylbutyrate is an agent known for its ability to induce differentiation, primarily by inhibiting histone deacetylase. In 1996, the United States Food and Drug Administration approved phenylbutyrate to treat urea cycle disease. More recently, in 2020, it has been repurposed for managing amyotrophic lateral sclerosis. Doctors from Emory University conducted a clinical study to evaluate the efficacy of phenylbutyrate in cancer treatment. The trial included 23 patients with recurrent malignant gliomas, located in the supratentorial region. During the study, a dose escalation approach was used to determine the maximum tolerated dose, which was found to be 27 grams per day. However, 1 out of 7 patients at the maximum tolerated dose experienced reversible grade 3 somnolence as a side effect. The median survival time from the start of the study was 5.4 months. Among the participants, 1 patient achieved a complete response that lasted for 5 years, while no partial responses were observed. As a result, the overall response rate was 5%. These findings establish the maximum tolerated dose and recommend a dose of 27 grams per day for heavily pretreated patients with recurrent gliomas. It is worth noting that the pharmacology of phenylbutyrate may be influenced by the concomitant administration of P450-inducing anticonvulsants. This clinical study provides valuable insights into the potential use of phenylbutyrate as a treatment option for recurrent glioma. Further research is needed to explore its effectiveness in larger patient populations. A randomized phase 2 trial evaluated the efficacy of combining the autophagy inhibitor, hydroxychloroquine, with gemcitabine and nab-paclitaxel in potentially resectable pancreatic tumors. Patients were randomly assigned to receive 2 cycles of nab-paclitaxel and gemcitabine, either alone or in combination with hydroxychloroquine, followed by surgical resection. The group receiving nab-paclitaxel and gemcitabine with hydroxychloroquine demonstrated significantly improved histopathologic responses compared to the control group receiving nab-paclitaxel and gemcitabine alone. Notably, there were no significant differences in serious adverse events between the 2 groups, and both groups received an equivalent number of chemotherapy doses. Furthermore, the specimens obtained from patients in the hydroxychloroquine group showed stronger evidence of autophagy inhibition and increased infiltration of immune cells into the tumor. This suggests that the addition of hydroxychloroquine to preoperative gemcitabine and nab-paclitaxel chemotherapy in patients with resectable pancreatic adenocarcinoma resulted in a greater pathologic tumor response, improved serum biomarker response, and evidence of autophagy inhibition and immune activity. Sulfasalazine is an intriguing drug, with established applications in the treatment of ulcerative colitis and rheumatoid arthritis. However, recent research has unveiled its potential in cancer treatment through repurposing. One of its key mechanisms is the specific inhibition of XCT-mediated cysteine transport, which plays a role in the proliferation of CD44V9 positive cancer cells. CD44 is cancer stem cell marker. By selectively targeting this transport mechanism, sulfasalazine effectively suppresses the growth of these cancer cells. The mechanism of action involves reducing the levels of glutathione, GSH, a crucial antioxidant, which consequently leads to an increase in intracellular reactive oxygen species levels. Reactive oxygen species is commonly referred to as ROS. This elevation of ROS triggers the phosphorylation of p38 mitogen-activated protein kinase. Ultimately, this process can induce apoptosis, or ferroptosis, 2 forms of cell death. A clinical study was conducted to investigate the efficacy of sulfasalazine in combination with cisplatin for patients with advanced gastric cancer who had shown no response to cisplatin monotherapy. Sulfasalazine was administered orally 4 times daily, in a treatment schedule of 2 weeks on and 1 week off, while cisplatin was given at a dosage of 60 mg per square meter every 3 weeks. Among the 15 patients enrolled in the study, none achieved an objective response. However, one patient completed 6 cycles of treatment and experienced stable disease for over 4 months. Furthermore, this patient exhibited a reduction in intratumoral glutathione levels. The combination of sulfasalazine and cisplatin was generally manageable, although dose adjustments were frequently required within the relatively short observational period. In summary, this study evaluated the use of sulfasalazine in combination with cisplatin for patients with advanced gastric cancer who did not respond to cisplatin alone. While no objective responses were observed, one patient demonstrated prolonged stable disease and a decrease in intratumoral GSH levels. The combination therapy was generally well tolerated, although dose modifications were frequently necessary within the limited duration of the study. In subsequent clinical trials, the efficacy of combining sulfasalazine with cisplatin and pemetrexed was investigated in chemotherapy-naive patients diagnosed with advanced non-squamous non-small cell lung cancer. Through a dose escalation study, a recommended daily dosage of 1.5 grams of sulfasalazine was established. The study yielded promising results, demonstrating positive outcomes for the patients. The overall response rate was 26.7%. This indicates a significant number of patients experiencing favorable responses. Additionally, the median progression-free survival was observed to be 11.7 months, surpassing those observed in previous studies utilizing cisplatin pemetrexed alone. Furthermore, the 1-year survival rate was reported as 73%. Significantly, the combination therapy of sulfasalazine with cisplatin pemetrexed was well tolerated by the patients, suggesting a favorable safety profile with minimal adverse effects. These findings provide compelling evidence regarding the potential efficacy and tolerability of combining sulfasalazine with cisplatin and pemetrexed in the treatment of chemotherapy-naive patients with advanced non-squamous non-small cell lung cancer. Leflunomide is a disease-modifying antirheumatic drug, DMARD. It was approved for the treatment of rheumatoid arthritis and psoriatic arthritis. Upon administration, leflunomide is converted into its active metabolite, teriflunomide, both in the intestines and plasma. Leflunomide exerts its effects by inhibiting the mitochondrial enzyme, dihydrorotate dehydrogenase, in short, DHODH. This will thereby disrupt the de novo pyrimidine synthesis pathway and halt cell growth. Additionally, leflunomide inhibits the activity of tyrosine kinase's platelet-derived growth factor receptors and epidermal growth factor receptor. Both are commonly expressed in tumor cells. Promising results from numerous preclinical studies have highlighted the potential antineoplastic properties of leflunomide in various types of cancers, including prostate, breast, bladder, multiple myeloma, leukemia, and lymphoma. A clinical trial conducted at City of Hope investigated the effectiveness of single-agent leflunomide in patients with relapsed refractory multiple myeloma. The study included 12 patients, and the results demonstrated successful treatment outcomes. Among the 11 patients evaluated, 9 achieved disease stabilization when treated with leflunomide. Notably, 2 patients experienced disease stabilization for nearly 1 year or longer. Regarding safety, leflunomide showed a well-tolerated profile at the dosage tested, with minimal observed toxicity. Only one patient at the 60 mg dose experienced elevated alanine aminotransferase levels. Overall, toxicities associated with leflunomide were rare and manageable. These encouraging findings, highlighting the favorable safety profile and potential for disease stabilization, provide a strong rationale for further investigations into leflunomide, either in combination with other drugs or as a strategy to delay cancer progression. In conclusion, the exploration of off-label medicines in cancer treatment has illuminated new possibilities and potential avenues for enhancing patient outcomes. The utilization of existing drugs for indications beyond their FDA-approved uses has demonstrated promise in targeting all cancer hallmarks, bolstering therapeutic effectiveness, and addressing unmet medical needs. While off-label use necessitates thoughtful consideration, it provides a valuable tool in personalized medicine, empowering healthcare professionals to tailor treatments to individual patients, based on their distinct circumstances and biological characteristics. The existing evidence unequivocally showcases that judicious employment of off-label medicines, backed by scientific evidence, can contribute to superior treatment outcomes and an improved quality of life for cancer patients. We must also bear in mind that the majority of clinical studies involving off-label medicine are often small in scale, and their results are considered preliminary. In fact, some studies yield mixed or inconclusive findings. It is crucial to acknowledge that there is still much work to be done in this field. Further research and larger-scale clinical trials are needed to better understand the efficacy, safety, and long-term outcomes of off-label medicine use in various medical conditions. Robust scientific evidence and rigorous evaluation are essential in order to establish clear guidelines and optimize patient care. As we continue to explore the potential of off-label medicine, it is imperative to approach its utilization with caution and adhere to evidence-based practices. Collaboration among researchers, healthcare professionals, regulatory agencies, and pharmaceutical companies is pivotal in fostering a comprehensive understanding of off-label medicine and its role in advancing cancer treatments. By recognizing the limitations and ongoing research in this area, we can collectively work towards addressing the gaps in knowledge and paving the way for future advancements. The provision of off-label medicine to cancer patients should be done through a shared decision-making approach. This means involving patients in the treatment decision process, considering their preferences, values, and individual circumstances. By engaging patients in discussions about off-label options, healthcare professionals can ensure that patients are well informed about the potential benefits and risks associated with such treatment. I would like to express my sincere gratitude to each and every one of you for your active participation in this insightful discussion on off-label medicines in cancer treatment. Together, let us persist in our quest for knowledge and collaboration, propelling the field of oncology forward and delving into innovative approaches in patient care. Once again, I extend my heartfelt appreciation to all of you for your invaluable contribution to this significant conversation. I want to dedicate my work to two mentors who have sadly passed away. One of them is Dr. Bernard Furgit, who was a highly respected figure in American hematology. He held the position of Professor of Medicine and was the director of the training program at Yale School of Medicine. Dr. Furgit was not only well known as a skilled clinician, scientist, and teacher, but he also taught me valuable lessons on how to ask important medical questions and approach each patient with compassion. His influence has had a profound impact on me and countless other students around the world. I will always remember and honor Dr. Furgit for his contributions to the field of medicine. Dr. Furgit's legacy will be cherished and remembered by many in the field of hematology and oncology. Dr. Joseph McKaylee was my mentor during my time at MSKCC, Memorial Sloan Kettering Cancer Center. He held the position of Associate Professor of Medicine and served as the Chief of the Multiple Myeloma Service in the Division of Hematology/Oncology. Additionally, he was the Director of Translational Research for Will Cornell's Center of Excellence for Lymphoma and Myeloma. Dr. McKaylee was a highly respected clinician and researcher who made significant contributions to the field of multiple myeloma research and treatment. Under his guidance, I learned how to think creatively and approach challenging topics such as cancer stem cell research and epigenetic therapy. He emphasized the importance of hard work and dedication in our endeavors. The impact of his teachings and mentorship will be deeply ingrained in my memory.
Omega Precision Oncology at the Institute of Integrative Bio-Oncology acknowledges and respects the intellectual property rights of others. We make use of copyrighted materials, such as pictures and tables for educational, research, commentary, criticism, and transformative purposes. The materials used are factual and informational, not for commercial gain, and only a reasonable portion necessary to convey the intended message is utilized. Our use of copyrighted materials is not expected to negatively impact the market value or potential for sales or distribution of the original work. While we strive to provide attribution to content creators, complete attribution may not always be possible due to platform limitations. We believe our use falls within fair use as defined by U.S. copyright laws. If you are a copyright holder and believe your work has been used inappropriately, please contact us so that we can address your concerns promptly.